So now let us start over here in the upper limb, which is the most important region as well as easiest also. The most common site for the fracture of clavicle is what? It is a junction of medial 2/3 and lateral 1/3. Okay, it will always remain this important, and we say this is the first best answer. If it is not given, then the second best answer is junction of medial 3/5 and lateral 2/5. A very important point over here. Now, when you are talking about the vertebral levels, a very important vertebral level, scapula inferior angle. What is the first best answer? T7, spinous process. Remember this spinous process. And the second best answer is T8 what? Body. It is a T8 body. So first you memorize for this, and then after that we say superior angle T2 and the spine of scapula is T3. So it is 2, 3, 7. Okay, from above to below, 2, 3, 7. And now in this image or in the X-ray image also, you should be able to identify what? Coracoid process. See, I have written over here E. E I have written because like this is like one of the point which can come as a new question. If you are saying that ma'am, this new question has come, so it can come as a new question which has not been asked earlier. So if you say new question has come, so for that I've marked over here E, which are like highly expected, which can come as new question. Then after that, humerus, very important. You should be knowing it by heart. All the landmarks you should be able to identify in the image, like the surgical neck, very important. Then shaft, in which you have the spiral groove, and on the medial side you are having the medial epicondyle. The three most important landmarks. Apart from this, you should be knowing greater tubercle, lesser tubercle, and intertubercular sulcus, which is also known as bicipital groove. And you can see I've written E for greater tubercle, very highly expected as a new question. If a new question comes, then it can come. In this also, you should be knowing all the landmarks. The other epicondyle is lateral, the round area is capitulum, and the other portion over here is trochlea. So you should be able to identify all the landmarks. Now, these points are the most frequently asked points for the humerus. The structure related to surgical neck, what? Axillary nerve and the posterior circumflex humeral vessels. The spiral groove, nerve related, radial nerve, and yes, profunda brachii vessels. And when you say behind medial epicondyle, it is ulnar nerve. It is the ulnar nerve. Now, the clinical aspect related to it, surgical neck fracture, axillary nerve affected. The dislocation of the shoulder, again the axillary nerve is involved. And if there is fracture of the shaft of humerus, then radial nerve is affected. Right? Now, if you say that, ma'am, some new question comes, then in the new question we say that this is a point which can come as new question, that what are the muscles attached to greater tubercle? And this we remember by this mnemonic sits. We say SIT. The first three letters are for greater tubercle, that is supraspinatus, infraspinatus, and teres minor. And the last S, subscapularis, is a muscle attached to lesser tubercle. Then over here we also say, what about the bicipital groove? The bicipital groove, we say that what are the muscles attached to it? It is the two majors, pectoralis major, teres major, and one more muscle is there, latissimus dorsi, which is specifically attached to the floor. Very important. Now for the radius ulna, one landmark each, which is important for you. Radius is having radial tuberosity, which gives attachment to what muscle? Biceps. And the ulna is having this hook-like projection, which is olecranon process, which is giving attachment to what? Triceps. So these 2 points are important for you in the radius and ulna. Now when you come to the hand, in this, a very important landmark is what? A very important landmark is scaphoid. The most commonly fractured carpal bone is scaphoid, and it represents as what? Tenderness in the anatomical snub box. Very frequently asked question. And this point you should be knowing. And when you say which is the most commonly dislocated, then the answer is lunate. Dislocation, lunate. Fracture, scaphoid. Right? Now for the brachial plexus, it is a high yield topic, and in this image, you should be able to identify pectoralis minor. And if you say, ma'am, what can be a question in this image, then yes, in this image you should be able to identify this nerve. This is the long thoracic nerve, right? Now when you talk about the brachial plexus, a very basic thing about the brachial plexus is how it is formed. So we say ventral, what? Ventral rami of C5 to T1. And now you should be knowing the components. Components are roots, then trunk, then division, and then the cord. When you talk about the trunk, like basic point about the formation is that three trunk are there, upper, middle, lower. In the upper trunk, you say upper two roots combine to form upper trunk, lower two roots combine to form the lower trunk, and whatever is left in the middle, it continues to form the middle trunk. Right, this is for the trunk. And when you talk about the formation of the cords, we say posterior means all posterior divisions. Okay, posterior means all posterior divisions are there. We actually remember for what? Lateral. We will remember for lateral. The lateral is formed by what? The lateral is formed by anterior divisions of upper two. Anterior division of upper and the middle trunk. Whatever is left, the anterior division of the lower trunk which is left is forming the medial cord. So we mainly remember which one? We mainly remember this one, lateral cord. Now as you talk about the branches over here, so the branches from roots, DSLR, DS is dorsal scapular, L is long thoracic. Long thoracic, very, very important. It is having the root value C5, C6, C7. And it is supplying a muscle, serratus anterior. Very, very important, this long thoracic nerve. Right. So when we are talking about the branches over here for the brachial plexus, you should be knowing that what are the branches coming from which portion and what is the root value. The root value is very, very important. Then after that point comes that it supplies what muscle. So over here we have said the root value of dorsal scapular C5. The muscle supplied is rhomboides major, minor and levator scapular. Then as you talk about the trunk, the mnemonic is SST, suprascapular nerve to subclavius, right? For the lateral cord, it is LML. LML is what? L is lateral pectoral nerve, M is musculocutaneous nerve, another L is lateral pectoral nerve. Sorry, the lateral root of median nerve. And in this, we say the musculocutaneous nerve, very, very important. Why? Because BBC, it is supplying three muscles, biceps, brachii, brachialis, coracobrachialis. So musculocutaneous, you remember musculocutaneous? Yes, biceps. And when you say medial cord, M4U, four branches from M, which are, medial pectoral, then we have medial root of median nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and very, very important, U for ulnar nerve. And for the ulnar nerve, C7, C8, T1. Very important root value. Then for the posterior cord, we say that it is having the mnemonic star. S is subscapular, two subscapular nerves, upper and the lower. And then after that, the T is thoracodorsal. Then A is axillary and R is radial. So first of all, you should be knowing all the branches coming from various portion. Axillary nerve, very, very important. It supplies what? Deltoid. And along with that, it supplies teres minor. Now, once you have memorized these branches, okay, once you have memorized these branches over here, which are coming from each of the portion, the next point comes the root value. For the root value, how we memorize is, first of all, you should be knowing the root value of these three, which are the most important. And we say median nerve, all, radial nerve, all the root value. And for the ulnar nerve, it is what? C7, C8, T1. Very, very important. Ulnar nerve. So first you memorize these three, and then after that we come to the rest of the root values. And for the rest of the root values also, we first of all memorize which? Yes, we first of all memorize these, which are easier to memorize. And we say the whole mnemonic SST is having C5, C6. Whole mnemonic LML is having 5, 6, 7. So this is the root value for whole of the mnemonic. So whatever branches over here, they are having this root value. And for M for U, yes, M is C8T1 and U is C7C8T1. So first of all, we memorize this. Then we come to DSLR. DS, C5, L. We say L is long thoracic, long. So means more nerve roots, 5, 6, 7. And now you come to the star. What is the star? Alternate alphabets. Alternate alphabets have C5, C6, means subscapular and axillary is having C5, C6. R radial we know all. Okay, that we already know it is all. And what is left? What is the left? What is the nerve left in the last? Is T, thoracodorsal nerve. So we say this is a nerve which is totally having a totally different root value, C6, C7, C8. So the one which is left in the last is having a totally different root value, which is C6, C7, C8. So this is about the brachial plexus. First you remember the branches, then you remember the root value, and after that point comes about the muscle supply. In that also, long thoracic nerve, serratus anterior, musculocutaneous, BBC, axillary nerve, deltoid and teres minor. Very, very important. Okay. Now, whenever we are talking about any of the component, during the class, whatever clinical aspect we have discussed, all the clinical aspect is very important for you, because you know that clinical integrated questions are being asked, so you should be ready for that. One liner questions you can all do very easily, but the problem comes in what? When the clinical question is there. So all the images of the workbook you should be seeing again and again. Whatever like clinical aspect we have discussed, you should be knowing all that clinical aspect, because already we have discussed the most important clinical aspect. Okay, so over here for the Erb's palsy, very important thing in any of the nerve injury, you should be knowing the nerve deformity, that what deformity is occurring in that due to the nerve injury, and secondly you should be able to identify in the image. So when I say Erb's palsy, it is the upper trunk of brachial plexus affected. What is the defect? Policeman tip deformity. It is basically a tip deformity. Policeman tip, waiter's tip, porter's tip. And this is the image. This is the image. So whenever you see the image, you should be able to identify. So this is the image, and very, very important point about this is position of limb is in adduction, extension at the level of elbow, medial rotation, and at the level of hand, pronation. So this point you should be knowing very well. Very, very important point about Erb's. And when you say clump case, the clump case, which trunk? Which trunk affected? Lower trunk affected. It is the lower trunk of brachial plexus affected. What is the defect? Claw hand. And when you're talking about the claw hand, what is happening at MCP? Yes, it is what? It is hyperextension at MCP and flexion at PIP and DIP. Okay, this is the claw hand and it looks like this. So this defect you should be knowing very well. And whenever we are talking about what muscles are affected, so the muscles of the hand are affected, in which specifically the lumbricals and the interossei are affected. Very important, lumbricals and interossei. Now, another thing is that we also mentioned that if by chance the sympathetic fibers are affected, it leads to Horner syndrome. What are the components? Ptosis, meiosis, anhidrosis, and ophthalmos, loss of ciliospinal reflex. And in that, we already mentioned that which is the most important over here, anophthalmos. You should be knowing that it is not exoph, it is actually anophthalmos. Okay, it is the anophthalmos. So please remember this, that in the Horner syndrome, it is anophthalmos. Now, in this pectoral region muscle, you should be able to identify pectoralis major, then pectoralis minor, and serratus anterior. This is one of the expected image for you, in which you should be able to identify in the anterior view as well as in the lateral view also, the serratus anterior, right? So image based question, if there, then you should be able to identify for the pectoralis major. Very, very important is what is the action. And how we memorize like this. This is what flex at the shoulder joint, flexion, adduction, and medial rotation. Okay, we remembered like this, that this is the position in the pectoralis major muscle action whenever the muscle is acting. And for the serratus anterior, what is very important is protraction of scapula. It is helping in the what? Protraction. Protraction is what? Scapula going away. So very, very important movement, which is one of the expected question for you as a new question, protraction of scapula. Apart from that, we say serratus anterior is a boxer's muscle. So triple P, pushing, punching, protraction, right? Now, when we are talking about this protraction, retraction, we say it occurs at what joint? It occurs at scapulothoracic joint. It is occurring at the scapulothoracic joint. And the retraction, now when the scapulas are coming towards each other, what are the muscles helping? So we say R for retraction, R for rhomboids. Both the rhomboids are there, plus middle fibers of trapezius. Okay, very, very important. Which fibers? Middle fibers. Now the clinical aspect over here is winging of scapula. You should be able to identify by the image. Nerve gone, long thoracic. Muscle gone, serratus anterior. Action gone, loss of protraction. And now you can see in this image which border of the scapula becomes prominent. It is the medial border, plus inferior angle of scapula, which becomes prominent. This is another clinical aspect which we have discussed over here. Now, as we talk about deltoid, we very well know in this image, this is the deltoid muscle at the shoulder. And in this, we have this very important movement, abduction at the shoulder joint. So 0 to 15 degree, supraspinatus, 15 to 90 degree is deltoid, and above 90 degree overhead abduction is by trapezius and serratus anterior together. These two muscles, they together act. Very, very important action of the in the upper limb, the abduction at the shoulder joint. Now, another clinical aspect which is very important is axillary nerve injury. When this occurs, the muscle affected is deltoid, teres minor. When the deltoid is gone due to that loss of abduction, 15 to 90 degree. And at the shoulder, the shape of the shoulder is gone, affected. So we say loss of rounded contour of shoulder. Plus, we say sensory loss here. So what is the location? Upper lateral aspect of arm. So regimental bad sensory loss, which is due to the involvement of upper lateral cutaneous nerve of arm, which is a branch of axillary nerve. So that is why sensory loss over here. Now in this image, you should be able to identify the muscles. We say that this muscle is a big triangular muscle is trapezius. On the lower side, this muscle is latissimus dorsi. And when we are talking about the three muscles over here, this muscle is levator scapulae, this one is rhomboides minor, and below this is a rhomboides major. This you should be knowing in image-based question. And very, very important for trapezius, we say that it is supplied by what? It is supplied by spinal accessory nerve, right? And it is spinal accessory is also supplying sternocleidomastoid. Now, a very important thing is this nerve is supplying two muscles. Very, very important. And what is the clinical aspect? If there's any injury, cut, or incision in the posterior triangle of the neck, it can injure spinal accessory nerve. And therefore, both the muscles are gone, trapezius gone, sternocleidomastoid gone. If the trapezius is gone, loss of shrugging. Very important, loss of shrugging. Loss of shrugging means patient is unable to elevate the shoulder and the shoulder drops. Okay, the shoulder drops. So because of loss of shrugging, the shoulder drops. Plus, the patient is having difficulty in turning the head or neck. So sternocleidomastoid is paralyzed. Due to that, we say the difficulty in turning the head or the neck. A very, very important clinical aspect over here again. Now, the next we talk about this scapular region area in which you should be able to identify the muscles. Whenever you are talking about the muscles over here, so what we say, above the spine of scapula, supraspinatus, below that infraspinatus, and two parallel muscles between the scapula and the humerus. In these two parallel muscles, the above one is minor, teres minor, and the below one is teres major. Okay. So these are the four muscles, very, very important to identify. And when we are talking about this muscle sits, the sits muscle, they combine to form the rotator cuff. The rotator cuff is a dynamic stabilizer of the shoulder joint. And whenever there is a rotator cuff injury, most commonly involved tendon is supraspinatus. And among the four, forgotten muscle is subscapularis. Okay. Now, when we are talking about the intermuscular spaces, okay, so when we are talking about the intermuscular spaces, over here we remember only 2 points. Quadrangular space, lower triangular. Okay, that's it. Quadrangular space where? Near surgical neck. Lower triangular space where? Lower. Because it is lower, so we say lower in the humerus, shaft. It is related to the shaft of the humerus. So we remember only 2 lines over here. Quadrangular space, surgical neck. Lower triangular space, yes, shaft or the spiral groove of the humerus. So if you remember these 2 points, you can answer other points automatically, right? So 2 lines we are memorizing over here. Whatever third space is left, we give it to scapula. That third space, you go to the scapula. And accordingly, the contents will be there. So these 2 points we remember over here. And in this image, you can yourself say that this is a quadrangular space, this is upper triangular, and this is lower triangular space. Now, when you are talking about the arm area towards the anterior side, BBC, all supplied by musculocutaneous, common action, flexion. Fine. And whenever you are talking about the muscles, this is the bicep muscle. Whatever muscle you see over here, this is a bicep. And when you remove the bicep muscle, what do you see? Two muscles deep to it. Above, coracobrachialis, below, brachialis. These are the three muscles, BBC. And a very, very important point about this is clinical aspect of this. And for that, we say musculocutaneous nerve. It gives a branch which is the lateral cutaneous nerve of forearm. So in which area? Lateral cutaneous nerve of forearm. And when the musculocutaneous nerve injury is there, so what will happen? It will lead to loss of flexion. One symptom, loss of flexion. Another symptom, sensory loss over here. What is this area? What is this area? This is a lateral aspect of the forearm. It is a lateral aspect of forearm. So when these two symptoms are there, it is musculocutaneous nerve injury. Now for the posterior compartment, only one muscle, tricep, supplied by radial nerve, action, extension, opposite action. So over here we now know for the arm area, anterior side, musculocutaneous, posterior side, radial. Okay, for upper limb and lower limb, please remember the nerve of each compartment. It will make it easier for you to memorize each and everything about that compartment. Okay, so arm area, musculocutaneous, radial nerve, posterior side. Forearm area, anterior side, median and ulnar, posterior side, radial. So radial is where always on posterior side. Now, when you talk about the forearm anterior compartment, what we memorized? We memorized all flexors and pronators. Whatever muscles are having the name flexors and pronators, they are in the anterior compartment, and the posterior compartment will be opposite, right? Posterior compartment will be all extensor and supinator. So if you remember this, you can automatically answer for the posterior compartment. So this is all flexor and pronator. For the anterior compartment, you should be able to identify in the image. When you see this image, the short muscle which you see is pronator teres, which ends in the middle of the forearm. The muscle which finishes at the wrist is carpi muscles. On the lateral side, flexor carpi radialis. On the medial side, flexor carpi ulnaris. Between these two muscles, the blue colored muscle which is shown as palmaris longus, which goes till the palm. Fine. As you remove all these muscles, you have flexor digitorum superficialis. The tendons are going to the four fingers over here till the middle of the fingers. These are the superficial group muscles. And when you remove all these muscles, then you have the deeper group muscles in which any tendon going to the thumb is pollicis, flexor pollicis longus. To the rest of the tendons is digitorum. And when you see this digitorum, it is going till the end of the finger. So this is what? Flexor digitorum profundus. And we say much deeper to it, we are having a quadrilateral muscle which is pronator quadratus. So you should be able to identify the muscles in the image. And now we say very, very important, the nerve supply, all are supplied by median nerve except two muscles by ulnar nerve. One is, we remembered like this, ulnar nerve supplying ulnaris. So one exception is ulnaris, flexor carpi ulnaris. Okay, one exception is ulnaris. Second exception you have to basically remember, medial half of flexor digitorum profundus. Very, very important. If you remember that ulnar nerve is supplying these two muscles, you can answer for the rest of the muscles. Then for pronation, supination, this is supination, this is pronation occurs at radioulnar joint, pronation by pronators, supination by supinator. Only you have to remember one muscle over here, which is biceps brachii, which is doing what? Supination. It is helping in the supination. Then in this image, you should be able to identify that the three tendons which are raised at the wrist, lateral side, flexor carpi radialis, medial side, flexor carpi ulnaris, in the center, palmaris longus. Now, the clinical aspect over here, it can be as a given, it can come as a clinical question. So you should be knowing very well, olecranon bursitis, student's elbow. When you say golfer's elbow, it is medial epicondylitis and the tennis is lateral. Very, very important. It can come as a clinical question. Now, when you say posterior compartment, in this we need to know less. You already know all extensors and supinator. Apart from that, the muscle's name you should be knowing is brachioradialis, anconeus, supinator. Three muscles, brachioradialis, anconeus, supinator, all supplied by radial. All are supplied by radial. And for image-based question, this is the image which you should be able to identify. You can see one of the expected image. If you see this image in which they have given you the anterior view, Then the lateral side is occupied by which muscle? It is the brachioradialis muscle. Okay, it is occupied by brachioradialis muscle. This is for the posterior compartment. When you come to the hand, very, very important for you is to identify this image, that these are what? These are the lumbricals. Counting from where? Thumb side, 1, 2, 3, 4. One of the expected question for you. So either this image is given to you or this image is given to you. This is also lumbricals. And what is very important is identification of the lumbrical 1, 2, 3, 4 and its nerve supply. 1, 2 by median nerve, 3, 4 ulnar nerve. Very, very important question in the hand, which is one of the expected question, new question. It can come as a new question. Then another thing is that in the hand also we memorize the muscles which are supplied by ulnar nerve. So the ulnar nerve supplies what? Ulnar nerve supplies third and fourth lumbrical, we just mentioned, all hypothenar, all introchai. Okay, first you remember this. Third and fourth lumbrical, all hypothenar, all introchai, and now we add into it one more muscle. And when I'm saying I'm adding into it one more muscle, so by that we remember it is ADD, adductor pollicis. So these are the muscles supplied by ulnar nerve, all rest of the muscles by median nerve. So we only remember for ulnar. So this is a very, very important point in the hand. And apart from that, we say the action done by lumbrical is this. What is this action done by lumbricals? L for L. And what is this action? At the MCP, it is flexion. And at the interphalangeal joint, it is extension. And this action is assisted, or we say it is held by both introchai. For the introchai, we say palmar introchai adduction of the fingers, dorsal introchai abduction of the fingers. So adduction, palmar, abduction, dorsal. So these are the actions which are done by these muscles. Now, as we talk about the anatomical snub box, as we already said again and again, medial boundary, medial boundary, medial boundary, IPL matches going on, or the T20 matches, you already know World Cup is going on. So please remember IPL, EPL, IPL, EPL. Most important muscle which is there is EPL. Always remember EPL is forming medial boundary. The rest of the two muscles are forming lateral. Okay, the medial boundary EPL. And very important point over here is anatomical snub box is scaphoid bone is present. So scaphoid fracture leading to the tenderness at anatomical snub box. Another is the content over here is the radial artery. When you talk about the radial artery over here, you can feel the pulsation at this point because the radial artery is one of the content of anatomical snub box. And the radial artery pulsation, a very important point is where you always feel the pulse. Yes, this is the radial artery pulsation. Whenever you're feeling the pulse over here, and now this is one of the expected question for you, which can come as a new question. What is the location? So if you do it over here, already you know that it is on which side? Lateral side. You're already putting your fingers on the lateral side. So lateral to the tendon over here, which is flexor carpi radialis. So it is lateral to flexor carpi radialis tendon. So this is for the radial artery pulsation. This is the image which they always ask for image-based question. The anatomical snub box. This is a medial boundary and this is a lateral boundary. The lateral boundary is more near the thumb. So that is the lateral boundary. Then for the flexor retinaculum, the structures passing deep to it is median nerve, tendons of FDP, FDS, FPL. Okay, FDS, FDP, FPL. And when we are seeing in this image, you can see this is a section over here. This is a flexor retinaculum. Just below that, median nerve. Below that, whatever 8 tendons are present together, 8 tendons, above 4 tendons, FDS. Below 4 tendons is FDP. And one tendon which is present separately towards the lateral side, that is the FPL, flexor pollicis longus. So you should be able to identify in this image. And a very, very important clinical aspect for this area is carpal tunnel syndrome, compression of median nerve and the tingling sensation where? Yes, lateral side of the hand, specifically lateral 3.5 fingers, the lateral 3.5 fingers and adjacent area. So whenever the tingling sensation is over here, lateral side, median nerve. And if I say tingling sensation on medial side, then you say it is a compression of ulnar nerve. So now for the median nerve compression, carpal tunnel syndrome, the test for this is Phelan's test, which will be positive. And now when you say ulnar nerve compression, two syndromes, cubital tunnel and the Guin canal syndrome, they are associated with ulnar nerve compression. Now when you say cubital fossa, so cubital fossa over here, the muscle on the lateral side, we already said which muscle is on the lateral side, brachioradialis is forming the boundary on lateral side, and medial side, a small muscle which is going like this, it is pronator teres. These two boundaries are important for us, medial and the lateral. Then we say a very, very important point over here. In the cubital fossa, you are taking the venous blood samples. Okay, you are taking the blood samples from here. From which vein? Median cubital vein. Very important clinical aspect. From here, you take the blood samples and for giving intravenous drugs. Then in the contents, we memorize by a very easy concept, MBBS, medial to lateral. MBBS is what? M is median nerve, B is brachial artery, another B is biceps tendon. These three are the main structures. The last structure, S, is like a smaller structure which is a superficial branch of radial. And the three first structures are very important. According to these structures, we also mentioned that the brachial artery pulsation is felt medial to biceps tendon. So we remember this according to this mnemonic MBBS, medial to lateral, right? So for the cubital fossa, MBBS. Now when we are talking about each of the nerves separately, we say that median nerve gives a branch, anterior-interosseous nerve, which supplies what? It specifically supplies the deep group of muscles. And the deep group is FDP, FPL, PQ. So anterior-interosseous nerve deep. And for the sensory supply, this is very, very important. The lateral 3.5 adjacent area, all supplied by median, and towards the medial side, the rest of the area, ulnar nerve. This is on the palm area. When you say posterior side, dorsum, so we say the ulnar area remains the same, but for the median nerve, only the nail beds. And whatever is the rest of the area left, that is by radial nerve. Okay, that is by radial nerve. This sensory supply very, very important, because you will answer all the, like you can answer all the nerve injury questions according to the sensory laws. And if you know the sensory laws position, that what can be the location, according to that you can quickly correlate with the nerve. Now the median nerve, if you see the previous questions, they have asked on ulnar nerve, they have asked on radial nerve. If a new question comes, it can come on median nerve. You should be knowing the name of the deformities, benediction, ape thumb, pointing index. You should be able to identify in the image. Ape thumb, it is actually what? Adduction of the thumb is here, adduction of thumb. In the benediction, what actually happens when you ask the patient to make a fist, these two fingers are unable to flex. So we say that the patient is unable to flex the index finger and the central finger. In the pointing index, when you ask the patient to hold the hands together, this index finger is unable to flex and it looks like as if he is pointing by index finger. So you should be able to identify by the image. And when we are talking about one test over here, the test is pen test. This is the image showing the pen test. So any image, if it is having a pen, of course that is a pen test. There is no other image having the pen. So this is what? Pen test. Now when you say ulnar nerve, for the ulnar nerve only one deformity is there. And what is that deformity? This is a partial claw hand, and there is clawing of medial two fingers. So when you see this image, this is a partial claw hand having clawing of only medial two fingers, and you know which two fingers. What is these two fingers? Little finger and the ring finger. They are going into clawing. Only one deformity. Associated with hypothenar atrophy and sensory loss, we already know what is the location of the sensory loss. So this is very, very important, the deformity over here. Then in the ulnar nerve, we have a very specific point that in the low lesions of ulnar nerve, the severity of deformity will increase. The point over here, it is increasing. This is known as ulnar paradox. So only in the ulnar nerve injury, we are having this ulnar paradox. In low lesion, what you have to remember, in low lesion, the symptoms or the severity of deformity will increase. So this is the ulnar paradox. Now, what are the three tests associated with the ulnar nerve? We have the Book-Frohman test, card test, paper test, Igawa test. All are with the ulnar nerve. When you see this image, A book will be there between the thumb and index finger in the book format test. And when the thumb becomes pointed, this is test positive. Paper test, you will be having a paper between the fingers. Igawa test, a pressure is put on outside to the fingers. So this is for the ulnar nerve. And when we say complete claw hand, when you say complete claw hand, what is it? It is the both nerves are affected. Median nerve also, ulnar nerve also. Now for the radial nerve, the point which is associated over here is wrist drop. One deformity only, wrist drop, which you can see over here, which is a loss of extension at the wrist. So we mainly say the main deformity is the wrist drop. What are the other words associated over here is the crutch palsy, which is the compression of radial nerve in the axilla. And when you say Saturday night palsy, it is a compression of radial nerve in the spiral groove. And we basically say that complete, like if the higher lesion is here, complete extension is lost. And that is why we mention the wrist drop also. Now in this radial nerve, mainly they ask about these points, but one of the expected question for us is this. If they specifically ask you posterior introitious nerve injury, if they specifically ask from you the posterior introitious nerve injury, then what will be there is only one symptom, finger drop. So in that question, they will say that extension at the elbow is okay, extension at the wrist is also almost okay, or weak extension is there, no sensory loss is there, but only one symptom is seen, which is the finger drop. Only one symptom is seen. The rest of the things are okay or just fine. And only one symptom seen, which is the finger drop. So it is specifically involved in the specific posterior introitious nerve injury. Very, very important. Now, when you talk about the arterial supply over here, first of all, you should be knowing this basic framework. Three branches of aorta are what? Brachiocephalic, left common carotid, left subclavian, right? And the brachiocephalic further divides into right subclavian and the right common carotid artery. This is the basic thing. Now, when you say subclavian, it continues into axillary, it further continues into brachial artery, and the brachial artery divides where? It divides at the neck of radius, at the level of neck of radius, into radial and the ulnar artery, and these two arteries again anastomose to form what? The palmar arches in the hand, the deep and the superficial palmar arch. Now, whenever we are talking about these arteries, we say subclavian artery, very, very important, and you should be knowing its branches. What are the branches? By that we remember, eat vitamin C, D, and sit comfortably. So subclavian artery is what? Vitamin C, D, and sit. Vit and sit is for first part. Okay, vit sit is for the first part. So when I say vit, first part, C second, D third. Vit is vertebral artery, internal thoracic artery, thyrocervical trunk. Then thyrocervical trunk further is having sit, suprascapular, inferior thyroid, and transverse cervical. So with sit, first part. C, costocervical trunk, second part. D, dorsal scapular artery, third part. So even if you remember the mnemonic, vitamin C, D, and sit comfortably, so you will be able to answer the question. With sit is from first part. Now after that, you should be able to identify the branches in the image, in which we say second and third part are giving one artery each. So easy to tell. But the main problem comes in the first part. And now from the first part, if you see any artery going downwards to thorax, only one artery having the word thoracic, internal thoracic. Okay, that is the internal thoracic artery. So any artery going downwards is internal thoracic. Opposite to that, any artery going upward, straight upward, vertebral artery. And then third artery is thyrocervical trunk, which is a very small portion, and then it quickly divides into the branches. One of its branch goes to the neck area, to the thyroid gland, inferior thyroid artery. And the rest of the two branches, if you see, they are going on the lateral side. This is the transverse cervical and subscapular. The same thing, if you see in this image, exactly the same thing is there in the first part over here. You can see exactly the same thing. Internal thoracic, this straight upwards vertebral, this is thyrocervical trunk, this artery in the neck, inferior thyroid, and the rest of the two branches going on laterally is transverse cervical and subscapular. Now, as you talk about the axillary artery, over here also very, very important, you should be knowing about the arteries, branches. Axillary artery also branches. And for the branches, we say first part, superior thoracic. Second part, yes, thoracoacromial, lateral thoracic. Second part is more important over here to remember. Second part. Third part, subscapular and anterior and the posterior circumflex humerus. And again over here you should be able to identify in the image. First part, one branch only, so easy to identify, superior thoracic. And then we say what is the main artery for us, which you should be able to identify is lateral thoracic. If you identify lateral thoracic, you will be able to identify the rest of the branches. And for the lateral thoracic, we say it is like running along with pectoralis minor. They are like sticking with each other. They're like very closely present. Pectoralis minor, just close to it, whatever artery is there is lateral thoracic. And any artery which is running parallel to this lateral thoracic is subscapular artery. So you identified subscapular also. And now from the second part, if you see any other branch coming from the second part, that will be of course thoracoacromial. Okay, so the any branch, any other branch coming from the second part will be now any branch coming from the second part, any other branch is thoracoacromial. And when you see the third part, whatever the rest of the branches are coming from the third part is circumflex humeral. And always they are forming a circle like this. You can see they are forming a circle because they are anastomosing with each other. So circumflex humeral always in a circle. So this is how we identify, and we say the main is lateral thoracic. Now we say these two are very main arteries, the subclavian and the axillary, and these two arteries, the anastomose, they branches anastomose with each other at the level of scapula. Now the point is which part? Subclavian artery, first part, starting part. Axillary artery, end portion, third part. So initial part of subclavian, last part of axillary. Okay, so you should be knowing the parts over here, and then you say what branches are anastomosing. So these are the branches which are anastomosing over here, all scapular arteries, along with that transverse cervical artery, all these arteries. And this is a clinical aspect over here, that if this is the anastomosis between the subclavian and axillary, then we say if there is any obstruction in between, so what will happen? The blood will be diverted towards this anastomosis, and it will be an alternate route of blood flow, and therefore the blood flow to the upper limb is maintained. This can be asked as a clinical question also. The arteries which are maintaining this blood flow to the upper limb is again these arteries. Okay. Now, as we are talking about the lymphatic drainage of the breast, in this very important is which is the chief lymph node draining it, that is the anterior group of axillary lymph node. And this anterior group is very important. It is related to what? Lateral thoracic vein. Then when we are talking about the lymph nodes, very important regarding the clinical aspect is levels. According to what? Pectoralis minor muscle. Levels according to pectoralis minor muscle. And in this we remember which level? Yes, we remember level 1. The level 1 is where? The level 1 is below and lateral. If you remember the level 1, you can answer the rest of the levels because the levels are going like this. They're going up. So we say level 1 is lateral and below. So we remember only this level 1 lateral below, and accordingly you can answer the rest automatically. Now for the dermatomes, very, very important. And when you say dermatomes of upper limb, we mention C5 to T1. What is the direction? Yes. So just remember C5 to T1, and this is the direction for dermatomes of upper limb. So when you say upper limb, this is the dermatomes for upper limb, and very, very important, as you can see over here I have written is expected. Very important is expected, which is what? Umbilicus. The dermatome of umbilicus is what? It is T10. The portion which is very much expected from you. So dermatome question can come because it has come once till now. It can be anytime repeated. They can ask you the upper limb dermatome, or they can ask you umbilicus. For the umbilicus, the vertebral level, if they ask you, the answer is different. For the vertebral level, first best answer L4. If it is not given, then junction of L3 and L4. So this is for the umbilicus over here. In the x-rays, this image is very, very important. As you can see, easy to identify and expected also as a new question. Okay, where I have written E is like I'm saying a new question if it comes. For that, I'm written E. So for over here, you should be very well able to identify surgical neck and shaft. Along with that, new landmarks which are important for you is coracoid process and greater tubercle. Okay, this is the location of greater tubercle. Then apart from that, if you see this next image in this, you should be able to identify radial tuberosity, olecranon process, and very important, medial epicondyle. So these two images are very, very important for us. And now as we talk about the joints, as we are expecting one question from this, in the joints, the main classification is this: fibrous, cartilaginous, and synovial. This is the main classification. In the fibrous, very important example is syndesmosis, where middle radioulnar joint over here. So syndesmosis, very, very important, middle radioulnar. If the image is given to you, you should be able to tell that this is the location of middle radioulnar joint. Fine. And if I am saying this one, this is the superior radioulnar. Towards the lower side, this one is the inferior radioulnar. And when we are talking about the superior and the inferior, the variety is pivot variety of synovial joint. So this image is very, very important for you. Very, very important. And very, very high chances that it is repeated. This question has already come, it can be repeated. This question came last year. Very high chances that it is repeated. Now, for the cartilaginous, we say that primary is known as synchondrosis, secondary is known as symphysis. You should be knowing these other names also. For the primary, the very important example is first costosternal joint. And for the symphysis, secondary cartilaginous, very, very important example is pubic symphysis, which you should be able to identify in the image, that this is the location of pubic symphysis. Now, as you talk about the synovial joint, ball and socket. Everybody knows hip joint and shoulder joint, but the joint which everybody does not know is talocalcaneonavicular, which can come as a new question for you. That this is which variety? This is a ball and socket. Then apart from this, for the ear ossicles, you should be knowing that malleus and incus. Between malleus and incus, it is what? Saddle. Between incus and stapes, it is ball and socket. So talocalcaneonavicular, very important. It is ball and socket. Then hinge is what? Hinge is elbow and interphalangeal. Whatever examples we are mentioning over here, they are very, very important. Then we just mentioned middle radio, the superior and the inferior radio ulnar. We just mentioned is pivot variety. Now in this, one more very important example is atlantoaxial. For the atlantoaxial, we say it is also considered as a no movement joint. Now again, this is one of the question which can come as new question. Either they will say no movement joint is which one, or they will say the joint no movement is what? You are doing like this. Okay, this is the no na. This is a no movement. They can also write that the movement in which the head moves to right and then it moves to the left. So again, this is what? This is a no movement joint. So in this movement is done at what? It is done at atlantoaxial joint. The joint is atlantoaxial. Then ellipsoid is wrist joint. Again, it can come as a new question. Okay, if they repeat, then most probably they ask about the radioulnar. And if a new question comes, these are the like expected questions which I have told you, which can come as new question. Then the saddle is first carpo metacarpal. And then very important, we say condylar is knee joint and temporomandible. Okay. Now coming to the types of epiphysis. For the types of epiphysis, if the examples are given to you, they are in front of you, the options, you should be able to identify that which one is pressure, which one is traction, which is atavistic, which is aberrant. Okay, for the pressure, we remembered what? We remembered weight transmission. Weight transmission where mainly in the lower limb, mainly on the hip joint and knee joint. In the lower limb, mainly hip joint and knee joint. So that is why these ends are there which are participating. In the upper limb, main location for the weight transmission is this and this. So that is why we have mentioned the ends over here according to that. So whenever we are answering the pressure epiphysis, remember what? It is related to weight. weight transmission. So those ends which are participating in the weight transmission. And when you say traction, traction means pull. So the ends which are associated by pull by muscles, which are having a lot of muscles attachment, like tubercles of humerus, trochanters of femur, mastoid process. And now, as you talk about the atavistic, one main example over here, coracoid process. And for aberrant, one main example is head of first metacarp. Okay, this is main example for these other two types. Now, when you're talking about the hybrid or the composite muscle, these are the two muscles. These muscles are the muscles with dual nerve supply. And when you are talking about the dual nerve supply, we remember by the mnemonic BP bad for the students. Okay, this we always keep telling you, na, be chill, be relaxed, be cool, don't increase your BP. So BP is bad for you. BP bad for the students. And now you have to practice it 2-3 times, and then you will remember all the list over here, that what are the muscles which are termed as hybrid muscles. So all these are hybrid muscles. First of all, B brachialis, P pectoralis major, pectineus, B bicep femoris, A adductor magnus, D digastric, F is flexor digitorum profundus, and the flexor pollicis brevis. Then T is trapezius, S is subscapularis. This you will have to repeat 2-3 times. And whenever you are memorizing a list like this, discuss with your friend, one friend or two friends. You can like make a group of two people who discuss with each other these kind of points so that you're able to memorize it well. Now, as we talk about the thorax portion, in this we say a very important point is sternal angle. What is the level? The angle of Lewis. It is also named as angle of Lewis. The vertebral level, what? Lower border of T4. Please remember over here borders also. Wherever we are mentioning the borders in the workbook, you have to remember the borders for that in the vertebral level. So what is it? It is a lower border of T4, and if it is not given, then you go for a junction of T4, T5, right? Now, in this, we remember this very important clinical aspect, which is very frequently asked for the pleural tap. You put the needle where? Yes, along the upper border of the rib. You put the needle along the upper border of the rib. Reason you know why? Because towards the low border, you have neurovascular bundle. So we remember only one point. We remember that we are putting the pleural tap needle along upper border of rib, upper border of any of the rib, upper border of first rib, upper border of eighth rib, upper border of seventh rib, any rib. Always it is upper border. Then as you talk about the mediastinum, in the mediastinum, superior mediastinum, a lot of structures because it is a common area. So how we remembered? We remembered two tubes, two vessels, four nerves, two other structures. Two tubes, trachea esophagus from here. Trachea esophagus, two tubes. Two vessels above the heart. Above the heart, arch of aorta, and one venous structure coming from above, superior vena cava. Then we said four nerves, phrenic, vagus, sympathetic trunk, and left recurrent laryngeal. Two other structures, thoracic duct and thymus. So two tubes, two vessels, four nerves, two other structures. Very important. And when we are talking about the nerves over here, in the image, you should be able to identify the location of nerve. If you see any nerve running down and it is present along with the heart, this nerve is phrenic nerve. So phrenic nerve is slightly on the anterior side. And when you come to the posterior side of image, the nerve which is running along with the esophagus, and it is on the posterior side of the image, this is a vagus. These two nerves you should be able to identify in the image. Then apart from this, when you see this image, you can see over here, this is a trachea. Behind it, this is the esophagus. The esophagus will, like starting from here, it is completely running down over here till this point. So if I draw over here, this is esophagus. This complete structure is esophagus. You should be able to identify it. Then in this image, this is the arch of aorta, which continues down into what? It continues down into descending aorta. So these are the basic structures which you should be able to tell in this image. And then, as you can see, along with the heart, the nerve which is present is phrenic nerve. So when we are talking about the middle mediastinum, the middle mediastinum, we mentioned what? Heart. We always said heart in the middle. Okay, on the inferior mediastinum divided into anterior, middle, posterior. Heart in the middle. So we say along with the heart, what other structure? Yes, it is a phrenic nerve. It is a phrenic nerve. Then apart from that, for the posterior mediastinum, what we memorized was EDTA salt. We remembered by the mnemonic EDTA salt, E, esophagus and vagus. So esophagus, vagus always together. Wherever you write esophagus, vagus will be there. So esophagus, vagus, D, descending aorta, T, thoracic duct, A, azygous venous system, S, sympathetic trunk. So this we have a mnemonic over here for the posterior mediastinum. So these three mediastinum are important for us. Now as we are talking about heart. Now in the heart, a very important thing is which chamber is forming which part. We say apex by left ventricle. The location of the apex is left fifth intercostal space, around you say 9 centimeter from midline. The same point is given the term as apex beat. So we say apex is formed by left ventricle. Then the base is formed by both atrium. The base is formed by both atrium. As you can see over here, both atrium, and in that we say left atrium mainly. So first you memorize the apex and then the base. Apex, left ventricle, base, both atrium. And now we come to the surfaces. For the surfaces, we say anterior surface, which is known as sternocostal surface, formed by all chambers except left atrium. So what are the chambers? Right atrium, right ventricle, left ventricle. The left atrium is not there because left atrium is on the posterior side. Now on the inferior aspect, we say known as diaphragmatic surface, and now both the ventricles are present on the diaphragm or on the inferior surface. So for the inferior surface, we have both ventricles. Now apart from this, we say you should be knowing the word fossa ovalis. What is this fossa ovalis? This is this oval shaped depression which you see in this image, present specifically where? It is present in the right atrium. So this word you should be knowing, fossa ovalis. In the image, this is this oval shaped depression. Where? Right atrium. Now for the heart, arterial supply very, very important. And in the arterial supply, you can see I've written expected also over here, that this is a point which is expected. First of all, in the arteries, you know, you are having the right coronary, you are having the left coronary. And we said which is the most important? Right coronary. And we always remember the right coronary first. So the arteries are arising from where? They're arising from ascending aorta, which is having 3 aortic sinus, right? And we say very, very important is right coronary, which is taking origin from anterior aortic sinus. The same you can see we have written over here. This is very much expected over here as a new question. Anterior aortic sinus, origin of what? Right coronary. Anterior aortic sinus, right coronary artery. And then we say left for left. So what is left is for left coronary. So left for left. Left posterior aortic sinus for left coronary. So basically you are having one anterior and two posterior aortic sinus, in which the left posterior you have given to this one, left coronary. Whatever is the third aortic sinus, we say that is a non-coronary sinus. So if you remember the anterior aortic, you can memorize the other two very easily. So we remember anterior aortic, right coronary artery, and when we are talking about the branches, again we memorize for right coronary. What is a branch? Piva. Okay, piva. Piva we say right. Again we are saying right coronary. Which one? Piva. Piva is what? Posterior interventricular artery. Always very important. Right coronary branch piva. If the piva is from here, we say left coronary artery gives the opposite one, anterior interventricular. So anterior interventricular, then left anterior descending, left circumflex. And again if you see left, left from left. So we remember like this, left, left from left. So first you remember The right coronary is piva, which is posterior interventricular. The other one anterior interventricular from left side, and the other two branches are left anterior descending, left circumflex. So if you remember the right coronary branch, you can answer the left coronary branch. And now again and again we are saying piva very important, piva very important. So that is why piva decides cardiac dominance. And in the case, if the left cardiac dominance is there, then piva is arising from left side, and that is only in very less individuals. In that case, the piva arises from where? It arises from the left circumflex artery, specifically from left circumflex. Okay, specifically from left circumflex. Now, a very, very important clinical aspect over here for the heart is when the angina is there, the pain is referred to which area or to which nerves. So the pain is referred to the dermatomes of what? To the dermatomes of T1 to T5. And apart from that, we say a very important nerve is there, which is intercostobrachial nerve. So you should be knowing this name, intercostobrachial nerve, which is actually a branch of T2. So remember the name for the angina of the heart, pain referred to intercostobrachial nerve, intercostobrachial nerve, intercostobrachial nerve. So intercostobrachial nerve is associated with pain referred in angina. Fine. Now, as we talk about the trachea, this is a cross section we have discussed. This is a cross section almost in the neck over here. And whenever you see the cross section, anteriorly trachea, posteriorly esophagus, trachea is having this C-shaped structure, which is what? C-shaped tracheal ring, hyaline cartilage, which is hyaline cartilage, and posteriorly it is filled by a muscle, which is trachealis. Then behind it, you have esophagus. Very, very important image. Very, very important image. And now when we are talking about the lung over here, we say another very important point about the lung is structure arching over the hilum. It is different on the right side, different on the left side. Very, very important. The structure arching over hilum of right side, azygous vein. On the left side, it is arch of aorta. It is arch of aorta. Very, 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 very important point over here. Now, as you're talking about the bronchopulmonary segments, you should be knowing the characteristics of the bronchopulmonary segment. And when we are talking about the characteristic, the main point over here is this. Which structure is running in the intersegmental area? The structure running in the intersegmental area is pulmonary vein. Okay, this is a pulmonary vein. The rest of the structures are going to the segment itself. And when we are talking about the rest of the structure, which bronchus? Tertiary bronchus. So in the bronchopulmonary segment, you should be knowing these two lines. First, you memorize this line. The pulmonary vein runs in the intersegmental area. And then you say the bronchus over here is tertiary bronchus. So what we say that bronchopulmonary segment is having everything of its own, except one structure, except pulmonary vein. Except pulmonary vein. Now, clinical aspect of bronchopulmonary segment. For the clinical aspect, we say segmental dissection. Can it be done or not? Yes, it can be done. It can be done. One clinical aspect. Another clinical aspect, foreign body aspiration leading to aspiration pneumonitis. Different segment affected in the supine position, and different segment is affected in the standing position. In both the position, supine or standing, we say it is always what? It is the right lower lobe which is affected. So for the foreign body aspiration, which side? Right side. Which lobe? Lower lobe. So right lower lobe is always affected. Okay, right lower lobe, only the segment is changing. In the supine position, it is a apical segment. In the standing position, it is the posterior basal segment. Mainly they ask about the supine, but you should be knowing both. So this is another clinical aspect which we have discussed. Then for the esophagus, this table, very, very important for you. In this table, location and the distance from incisor teeth in centimeter. This portion, very, very important for you. First constriction, beginning point, which is a cricopharyngeal junction or the pharyngoesophageal junction. Second, when it is crossed by aorta, arch of aorta. Third, when it is crossed by left bronchus. Fourth, when it is passing through diaphragm. So you should be able to tell the location of the constriction. Then after that, you should be able to tell in the centimeter that how much distance from where incisor teeth. So it is 15, 23, 28, 40. This is a standard. This is a standard 15, 23, 28, 40, 15, 23, 28, 40. Now, this can be asked as a clinical question, like if they say endoscope is being put and the endoscope reaches 23 centimeter. So it is at which landmark? It is at arch of aorta. If the endoscope has reached, like we say 40 centimeter of endoscope we have put inside, so it has reached which landmark? It is reached till the diaphragm. So this can be asked as a clinical question regarding endoscopy. Fine. Now for the diaphragm, the nerve for the diaphragm is phrenic, which is C3, C4, C5. And when we are talking about the diaphragm, very, very important is this image. Very important. And when you are seeing this image, you should be knowing the basic landmarks and you should be able to tell that which is the anterior side, which is the posterior side. The posterior side is the one which is having projections, tail-like projection, which is known as crus. So it is like smooth area on all the side, but on the posterior side, some projection is there, crus. Between the two crusts, this area is thickened to form median arcuate ligament. On the anterior side, this greenish area is central tendon, and the rest of the brown area we say is the muscular part. We have written over here muscular part. And now we say from anterior to posterior, there are three openings. We can see over here it is mentioned three openings, voice of America. So first when you see the image is very important. You should be able to tell anterior and the posterior side, and then you see three openings and apply the mnemonic voice of America. Vena cava opening, esophageal opening, aortic opening. So you should be able to first of all identify in the image, and then as we say voice of America from anterior to the posterior. VOA 8, 10, 12. Vertebral levels. Vertebral levels what? VOA T8, T10, T12. So VOA T10, T8, T10, T12. So VOA 8, 10, 12. Now after that we say what are the structures passing through aortic opening. This is the most important opening over here, the aortic opening, and we say the structures passing through it is aorta, thoracic duct, and azygous vein. So first of all you memorize for aortic opening, aorta, thoracic duct, azygous vein. Very, very important. So first of all you memorize for the aortic opening, which is the most important, and then you memorize for the rest. So main is the aortic opening over here for the diaphragm. Now as we talk about the thoracic duct, for the thoracic duct, very important, it opens at which point? Thoracic duct left. So both the veins are where? Left. Both are veins on the left side. So it is opening at the junction of left internal jugular and left subclavian. Right? It is opening at this junction. This is always the first best answer. If it is by chance not given, then you can go for this second answer. But always it is the first best answer. And when you are talking about this thoracic duct, in this image you can see this is a formation of superior vena cava, and this is the thoracic duct opening at the junction of this left internal jugular and the left subclavian vein. Fine. Now, when you are talking about superior vena cava, a very basic thing, it is formed by union of what? It is formed by the union of, you can see over here, right brachiocephalic and the left brachiocephalic. Both of them, they combine to form superior vena cava. And now the brachiocephalic vein is formed by what? The brachiocephalic vein is formed by the union of internal jugular and subclavian. And it is same on the right side, same on the left side. You can see it is same on both the side. So internal jugular and the subclavian vein, they combine to form the brachiocephalic. It is same on the right and same on the left. Now, another important vein over here is azygous vein, which is present on the right side. Only one unpaired structure. It is only on the right side, and it opens where? It drains into superior vena cava. This is a very, very important point. It drains into superior vena cava. Okay, it is draining into the superior vena cava. Now after this, you should be having the orientation of this image. When you see this image, this is a vertebral column. In front of the vertebral column, when you see any structure, So in front of this vertebral column, this structure over here is descending aorta. And as you go in front of it, this structure is esophagus. As you further go in front of it, this area is heart area, and front of it, this bone is sternum. So first of all, you should be having this orientation that what are these structures, and they have this orientation only when you see the transverse section also. So when you see the transverse section, this is this transverse section taken at that level only. So when you see transverse section, you first of all identify vertebra and the sternum. Okay, this is the vertebra and sternum. According to that, anterior and the posterior side. Now let us start from vertebra. Vertebra, in front of vertebra, whatever structure or section you see is what? It is a descending aorta. In front of that section is esophagus. In front of that, you have this big section which is heart. And then in front of that, sternum. So these structures in the midline, they are having the same orientation, and on the sides, you are having the lungs. In the heart, we say which is the chamber on the most posterior side. This is the left atrium. So this is a very, very important transverse section over here, which you should be able to tell. And now if I say that we take one more section, if I take one more section above the heart, so in this section, we will see all the vessels. Now over here, everything will remain the same. Everything will remain the same, but apart, like at the location of heart, you will see vessels. So now what you will see over here is that same orientation, vertebra in front of that, descending aorta in front of that, esophagus. So same orientation is there. Let us see this image also, another section. In this another section, again, this is a vertebra and this is a sternum. This is the anterior side and that is a posterior side. Now, when you see the vertebra, in front of the vertebra, descending aorta. In front of it, esophagus. Same orientation. But now a different structure is there. One more big circle you see on the anterior side, and now there's one more big circle which you see on the anterior side is ascending aorta. So that is what is important to you. Whenever you see this section, you see big circles. You see two big circles, and they are what? They are aorta. They are sections of the aorta. And you already know this is a descending. The other one circle, which is on the anterior side, is ascending aorta. And along with the ascending aorta, whatever other small section you see is what? It is the superior vena cava. Okay, that section is superior vena cava. So over here, we have identified two other structures is ascending aorta and superior vena cava. These are important for us. And if you see what is present in between this component is pulmonary trunk. But the main is identification of the aorta over here. Now, when you're talking about the head and neck portion, so when we are talking about the head and neck portion, over here we say that in the superior view we are having a structure over here, bregma. So whenever the image is there, you should be able to identify the bregma over here, that this is the location of the bregma, and this is what? This is the anterior fontanelle. A very, very important point about this bregma or the anterior fontanelle is that when does it close? It closes by 18 to 24 months of life. So which age? 18 to 24 months. And then we say which is the last to close. The last to close is again the bregma. So this is a point very, very important. Bregma. Over here, last to close. Then after that, in this image, you should be able to identify what? Pterion. That when you are talking about this landmark over here, this is what pterion. And what is important about this is what is present deep to it. So the structure which is present deep to it is middle meningeal artery. So that is why if the middle meningeal artery, if it is mentioned that it is ruptured and it is forming an extradural hemorrhage, then we say the injury is at which point? The injury is at this point, which is pterion. So pterion, deep to it, middle meningeal artery. What other structure? What other structure? Yes, the other structure is a part of the brain, which is the lateral sulcus of cerebrum. Okay, so other structure deep to it is brain, lateral sulcus of cerebral hemisphere. Now, apart from this, when you are talking about the foramens, so we first of all memorize which one? We first of all memorize this ovale. Ovale male. The mnemonic is ovale male. Ovale male. And what is the cranial nerve passing through it? M for mandibular nerve, And then you say like other structures are accessory meningeal artery, lesser petrosal nerve, emissary vein. So this is the most important foramen. Whenever you are memorizing the foramen, this is the most important foramen, ovale male. Then after that, we remember the rotundum. It is giving passage to maxillary nerve, and the spinosum is giving passage to middle meningeal artery. Then one more foramen we remember is jugular foramen. The jugular foramen we say 9, 10, 11. Okay, it is 9, 10, 11. And one jugular structure is also passing through it, which is internal jugular vein. So first of all, ovale, male, mandibular nerve, and then in front of it, rotundum, which is maxillary nerve, and spinosum, middle meningeal artery, jugular foramen 9, 10, 11. Okay, it is 9, 10, 11 along with internal jugular vein. Now, when you see this image, these three foramens you should be able to identify in the image. Posterior side, foramen magnum, anterior side, cribriform plate. This is a cribriform plate. And in the middle of the image, you will see a oval shaped foramen, which is the foramen ovale. And if I just zoom it over here, this is one foramen which is specifically seen as an oval shaped foramen, and it is in the middle of cranial cavity. So in the middle of cranial cavity, any oval shaped foramen is foramen ovale. Now for the sphenoid in this image, you should be able to identify, this is for image based question, in the anterior view of sphenoid, at this location, the foramen which is present is what? Foramen rotundum. Okay, this is foramen rotundum. Now as you talk about the orbit over here, so we should be knowing that what are the structures forming its walls, and in that we very well remember for the bony orbit, medial wall. Very, very important, medial wall U-assembly. So U-assembly, very easy mnemonic for this medial wall. So first of all, we remember U-assembly medial wall. U-assembly medial. What is this? SMLE. S is sphenoid, body of sphenoid. M is maxilla. L is lacrimal. E is ethmoid. So U-assembly is a mnemonic for medial wall of orbit. Then as you say floor, floor you remember? Yes. Palatine, zygomatic, maxilla. Okay, we remember the mnemonic pajama. So palatine, zygomatic, maxilla. So first we memorize the medial wall, then we memorize the floor, and after that we say the roof is formed by frontal plus sphenoid, lateral wall is formed by zygomatic plus sphenoid. So U-assembly medial wall, for the floor we say pajama, and then we say roof frontal plus sphenoid, lateral wall zygomatic plus sphenoid. These are the walls over here, and now when we are talking about a very, very important structure over here, we say lacrimal sac. Okay, whenever we are talking about the lacrimal sac, it is related to which wall? So when you say lacrimal sac, it is related to which wall? So always remember for the lacrimal sac. Remember for lacrimal sac, one structure. One structure you remember, lacrimal sac is medial wall. And the other one you will automatically say that if they ask about the lacrimal gland, then the lacrimal gland is where? It is towards the roof. So we remember for the lacrimal sac that it is on the medial side. Okay, lacrimal sac is on the medial side as it is mentioned over here. And the other structure, lacrimal gland, is at the location of the roof. So remember lacrimal sac on the medial side. Now over here, when we are talking about the foramens in the bony orbit, a very, very important foramen is supraorbital fissure, divided into these three compartments over here. And whenever we are talking about the three compartments, you can see it is divided into three compartments like this: medial, then this is intermediate and lateral. Now very, very important that what are the structures passing through it. And what we remember is, first of all, we remember lateral. The mnemonic very simple, LFT super. LFT super. You say LFT is what? Nerves. So LFT is super. Lacrimal, frontal, trochlear, super is superior ophthalmic vein. So lateral compartment, LFT super. Then you say intermediate. Intermediate is NOA. All the three nerves, NOA. Nasociliary, oculomotor, abducent. And whatever is the third compartment left, you say, oh, it is like inferior ophthalmic vein. The medial compartment, which is the third compartment left, it is having no nerve passing through it, only vein, inferior ophthalmic vein. It is inferior. Okay. So lateral compartment, LFT super. Then you say intermediate, NOA. Medial compartment, inferior. It is inferior. The third one which is left is inferior. So this is for the each compartment. You should be knowing that what are the structures passing through it. Now, as we talk about the mandible, a very important landmark over here is mandibular foramen, which you should be able to identify in this image over here. And it gives passage to what? It gives passage to inferior alveolar nerve and vessels. So any nerve and vessels going to the mandible, going where? Inferior. It is going on the inferior side. So we say inferior alveolar nerve and vessels. It is going inferiorly to supply the lower teeth. So inferior alveolar nerve and vessels. Now, as we talk about the cervical vertebra, very, very important. Vertebra prominence is C7. Then we say the characteristic feature over here, foramen transversarium, which is actually giving passage to what structure? To vertebral artery, where specifically C1 to C6. Only C6. You remember this. Not C7. C1 to C6. Vertebral artery. Now, a very, very important point over here, which is like expected as a new question, is common carotid artery pulsation. When you're taking this common carotid artery pulsation, you press against which tubercle? Carotid tubercle, Casonic tubercle. Which vertebra? C6. Very important point. Then for the vertebral for the vertebral levels, we said in the head and neck we are having two important vertebral levels over here. One is the junction of C3, C4, another is the C6. C6 we just mentioned this here also, and now we are mentioning again over here also. Now for the junction of C3, C4, we said it is towards the upper side. So we say upper border of thyroid cartilage, C6 on the lower side. So lower border of cricoid cartilage is corresponding to the lower border of cricoid cartilage. Now, if you say C6, another landmark, another event is happening over here. Pharynx, larynx finish over here, they end over here. Therefore, the trachea esophagus begins over here. So these two vertebral levels are very, very important in the head and neck. Then for the hide bone, we say another vertebral level is there, which is C3, only at one. The dangerous layer of scalp is loose connective tissue layer, fourth layer, or it is also known as subamniotic layer. Okay, the dangerous layer of scalp is which one? Answer is loose connective tissue layer, subamniotic layer, or the fourth layer. Then another clinical aspect is black eye. Another clinical aspect over here is a black eye. So when you are talking about this black eye over here, we say that it is due to which layer? It is due to the attachment of which layer? It is due to the attachment of this epineuritic layer. So there is some different, there's like some attachment of epineuritic layer which is different. Due to that, the black eye occurs. What is the main thing? In the epineuritic layer, the frontalis muscle, you can see frontalis muscle is not having any bony attachment. And because the frontalis muscle is not having any bony attachment, so due to that, what happens? Whatever blood, during any head injury, the blood, whatever blood is accumulated, it will go down along with the gravity towards this eye area. And it collects around the eyes, leading to black eye. So that is the reason. And we say the basic layer, the basic thing is that the layer which is responsible is the epineuritic layer attachment. In that also, frontalis muscle attachment, it is having no bony attachment. Then we say the black eye, it occurs. When does it occur? It occurs immediately or after few hours. So we say it occurs after few hours of injury. So two clinical aspects which are associated with the scalp, the dangerous layer of the scalp, and black eye. When you say face, in the face we say very, very important, the skin over the angle of mandible. The skin over the angle of mandible supplied by greater auricular nerve. So for the supply, skin supply, sensory supply, skin over angle of mandible. It is a greater auricular. For the muscles, very, very important is muscles of mastication. By what? Muscles of mastication by mandibular nerve. Okay, these are the exceptions over here. So we say muscles of mastication by mandibular nerve. So for the sensory supply, the complete face is skin is supplied by trigeminal nerve, except the skin over the mandible, which is greater auricular nerve. When you talk about the muscles, all the muscles of face are supplied by facial nerve, except muscles of mastication by mandibular. And you should be knowing what are the muscles of mastication. It is temporalis, masseter, over here masseter. Okay, temporalis over here, masseter, and two pterygoids, medial and lateral. The medial and lateral. Now the clinical aspect over here is that dangerous area of the face. What is the dangerous area of face? Neck. This is this dangerous triangle also you can say. The nose, upper lip, and the adjacent area. And it is drained by what? It is drained by the vein which is present near to it, facial vein. And the facial vein, it takes the infection to which area? To the cavernous sinus. So very very important, you should be knowing the location of the dangerous area of face, drained by facial vein, going where? Cavernous sinus. It is going to the cavernous sinus. And in this flow chart, this is the main route of spread of infection. From the facial vein to deep facial vein, then to the pterygoid venous plexus, then MS3 vein, and then cavernous sinus. So very very important, dangerous area of face, to the facial vein, and finally to the cavernous sinus. Now, when you talk about this cavernous sinus, we say what are the structures related? Like whenever you are saying cavernous sinus, most important venous sinus in the cranial cavity. And therefore, its relations you should be knowing. The lateral wall related to three structures: trochlear nerve, oculomotor, ophthalmic. Yes, very correct. So this oculomotor nerve, oculomotor, ophthalmic. These are the three nerves which are related to lateral wall. And when you say the structures passing through cavernous sinus, these are the structures towards the medial side, and we say it is abducent and internal carotid artery. Very very important, you should be knowing the relations over here regarding it. And if you remember, we memorized by the mnemonic aim the tool. Okay, remember by that mnemonic aim the tool. Aim is the mnemonic for the medial wall structures, the medial side structures, and tool is a mnemonic for the lateral wall. So we remembered by this mnemonic, tool for lateral side and aim for medial side. So these are the structures which are related to cavernous sinus. Fine. And if I'm saying that these are the structures or these are the nerves related to the cavernous sinus, if the infection reaches to the cavernous sinus, so it is going to affect which nerves? Of course, it is going to affect these nerves only. And if you see in these nerves, we are having 3, 4, and 6. 3, 4, 6 what? 3, 4, 6, the nerves for the extraocular muscles. One more nerve is there, ophthalmic. So if the cavernous sinus thrombosis, now this is a clinical aspect over here, if the cavernous sinus thrombosis occurs, what do you expect? Yes, you will expect 3, 4, 6 gone. And if the 3, 4, 6 is gone, extraocular muscle gone. Then another nerve you expect is this one, which is ophthalmic nerve. If the ophthalmic nerve is gone, then pain in the forehead, because this is the area supplied by ophthalmic nerve. The skin over here is supplied by the ophthalmic nerve, so the pain in the forehead. So according to the structures which are related, you can tell that what can be the symptoms. 3, 4, 6 gone, ophthalmic nerve gone, and venous congestion. Because the venous congestion is there, the pressure is there from inside. So the pressure is like this. And when we say the pressure is like this, so pressure on the eyes, and the eyes goes out, exophthalmos and periorbital edema. So these are the symptoms seen in cavernous sinus thrombosis. Now, as we talk about the arterial supply, a very, very important thing is that when you see this image, you should be able to identify the branches over here in this image. Very much like expected question, new question for you. It can come as a new question for you. And now, apart from this, you say, when you see this image, by this schematic image, you can answer all the arteries. And the very, very important artery is which one? Facial, which is running obliquely in the face. It is running obliquely in the face like this. So this is what? Facial artery, running obliquely in the face. Now, what are the branches of the external carotid? Sulfopams. What is it? SU, superior thyroid, L, lingual, F, facial, O, occipital, P, posterior auricular, A, ascending pharyngeal, M, maxillary, S, superficial temporal. And how we remembered? Yes, like this. External carotid over, and this one going above is superficial temporal. So these are the two terminal branches. So these are the two terminal branches. So these two are the terminal branches. And when you say first branch, the first branch is written first in the mnemonic. Superior thyroid, smallest is ascending pharyngeal, and the terminal branches we already mentioned, maxillary and the superficial temporal. Now, apart from this, we say the superior labial artery and the tonsillar artery, it is the branches for the facial artery. The tonsillar artery, it is for palatine tonsil, And when we are talking about the middle meningeal artery, which is a very, very important artery over here, we say it is a branch from the maxillary. It is a branch from the maxillary. Now, when you are talking about the lymphatic drainage, over here you should be knowing the components of Valdes ring. The components of the Valdes ring is palatine tonsil, pharyngeal tonsil. The pharyngeal tonsil is also known as adenoids. Then you have tubal tonsil and lingual tonsil. So you should be able to tell the name of the tonsils over here for the Valdes ring. Now, a very, very important aspect over here is parasympathetic ganglia. Very, very important. Parasympathetic ganglia. And yes, the mnemonic over here we remember was COPS 3977. So we remember by this mnemonic COPS 3977. And what is this 3977? It is the cranial nerves which are related to the four ganglia. So first you remember the cranial nerves which are related to it, 3977. For the pterygopalatine, the specific branch of facial nerve which is related is greater petrosal nerve. For the submandibular, the specific branch of facial nerve which is related is chorda tympani. So first you memorize the nerves which are related, then after that the structures which are supplied. So first of all, easier one, the same named structure, ciliary, ciliaris, submandibular, submandibular. So the same named structures are supplied by it, ciliary, ciliaris, submandibular, submandibular. And then you say what? Yes, otic, otid. So rhyming is there, same rhyming, otic, otid, otic, otid, parotid gland. And now you are left with only one, which is lacrimal gland, which is supplied by pterygopalatine ganglia. So this table is very, very important for you because multiple questions are solved by this table. Very, very important table for you. Multiple questions solved. Then as you talk about the parotid gland, among all the salivary glands, the main is parotid. For the parotid gland first, what is the duct? Duct is known as Stenson duct. Opens where? Near upper second molar tooth. Over here you should be knowing all the three words, upper second molar, upper second molar. Over here, this is the location of parotid gland and the duct is going like this. This is the location of duct of parotid gland on the upper side, upper second molar. Then after that we say there are three structures which are passing through it, the facial nerve, retromandibular vein, external carotid artery. These are the three structures passing through this parotid gland over here, the facial nerve going like this, the external carotid over here, and the retromandibular vein also over here. And among the three, the most superficial is facial nerve. Then a very, very important aspect which is like can come as a new question is Fraze syndrome. In the Fraze syndrome, the patient will be having the parotid gland surgery. Now this is one more clinical aspect. Parotid gland surgery is there, and after that there is injury of auriculotemporal nerve, which leads to Fraze syndrome. What happens in the Fraze syndrome? When the person is eating something, so while he is eating, there will be redness, increased temperature, and sweating on the lateral aspect of the face or on the cheeks. So whenever you see this typical symptom, you say it is Fraze syndrome. Okay, it is a Fraze syndrome, auriculotemporal nerve injury. Now for the temporomandibular joint, we say very, very important is movements. In the movements, we say depression. The most important movement is depression of the mandible. So when you say depression of the mandible, it is by which muscle? It is by lateral pterygoid. Which muscle? Lateral pterygoid. So for the movements, we remember first, very, very important, depression of mandible, lateral pterygoid. And if you remember this, we say elevation by rest of the three muscles. So the elevation is by rest of the three muscles. So first we remember this, very, very frequently asked, depression, lateral pterygoid. Now after that you say that this is a main movement actually which is done by the muscles. Now apart from this, the other movements can be retraction and the protraction. Protraction is protrusion of the mandible by both pterygoids. So when you say protraction by both pterygoids, so P for P, both pterygoids. So which is that protraction? Protraction is protrusion. And when you bring back the mandible, this is retraction. The retraction is when you're pulling back the mandible. So for that you require a big muscle which is temporalis. So protraction by P, pterygoids, and retraction by temporalis. So very, very important over here, depression by what? Depression by lateral pterygoid. Now, when you're talking about the neck, in the neck on the lateral side over here, we are having this carotid sheath, and you should be knowing that the carotid sheath is enclosing what structures? Artery what? Yes, carotid arteries. Vein what? Internal jugular vein. Nerve what? Vagus nerve. Mainly you should be memorizing over here that the nerve is vagus, because they will give you other options also. So artery is common carotid and internal jugular vein, and the nerve is vagus. It is a vagus nerve. Now on the lateral side only we have a nerve loop known as ansa cervicalis, for which we remember by SOS, that ansa cervicalis supplies SOS, sternocleidomastoid, omohyoid, sternothyroid. So ansa supplies SOS, these three muscles in the neck. It is in the neck over here. Now, when you are talking about the thyroid gland, a very, very important point is that it is supplied by this thyroid arteries, the superior and the inferior thyroid artery. But sometimes there is one more artery known as thyroidea ema artery. So if the thyroidea ema artery is there, it is taking origin from where? It is taking origin from arch of aorta. This is a question which they actually ask you. Thyroidea ema artery takes origin from where? Arch of aorta. Very important point in the thyroid gland. Another important point over here is that parathyroid artery. For the parathyroid gland, the parathyroid artery, it is taking origin from where? It is taking origin from inferior thyroid. So the parathyroid artery, it is taking origin from inferior thyroid artery. Now for the extraocular muscles over here, we say a very, very important aspect is that what is a nerve supply? When you talk about the nerve supply over here, we remember by this mnemonic LR6SO4. LR6SO4. What? LR6SO4. Two mnemonics in the in this eye area, LR6SO4. Another is SYNRAT. LR6SO4 is what? All the muscles supplied by oculomotor except LR6SO4. LR6 is lateral rectus by cranial nerve 6. SO4 is superior oblique by cranial nerve 4. So this is for the nerve supply. Next thing is SYNRAT. So we say that when we are talking about these three muscles, they are doing the action according to the name. Medial rectus is on the medial side, so it pulls the eyeball medially. Adduction. Lateral rectus, lateral side, it pulls the eyeball outside. Abduction. And levator palpebrae superioris, going in the upper eyelid, it causes retraction of the upper eyelid. So these three muscles are doing one action each according to the name of the muscle. And then we are having these four other muscles which are having 3 action each. And in that we say that superior and the inferior rectus, they do movement according to the name. Superior rectus helps in elevation, inferior rectus helps in depression of the eyeball. But when you say obliques, the obliques are, we say, are having certain different type of movement. The superior oblique will do different movement. It will help in depression, and the inferior oblique will help in elevation. So for the obliques, we say they do opposite movement, and the superior oblique helps in depression. So that is why you can see this is very, very important. This action done by superior oblique, it is very important that it is doing depression. Then the rest of the movements we remember by this mnemonic SYNRAD. What is this SYNRAD? SYNRAD is, syn is superior intort, rad is recti adduct. Superior intort, recti adduct, and now we put this mnemonic into this over here. So superiors, when I talk about superior, so superior, it helps in intorsion, superior's intort, and the rest of the muscles will do opposite action. Recti adduct, rad, recti adduct, and the rest of the muscles will do opposite action. So by this we are able to tell the action which is done by each of the muscle. And already very, very important is superior rectus is doing what? It is helping in elevation, intorsion, and adduction. So these are the movements done by superior rectus. So you should be able to tell about each of the muscle. Now when you are talking about the oculomotor nerve lesion, we say the 2 key points over here are these, in which the first most important key point is down and out position of the eyeball. So down and out position of eyeball, another key point is fixed and dilated pupil. So these two key points very important for oculomotor nerve lesion. The down and out position, you know, it is due to the unopposed action of the two muscles LR6, SO4. So when the oculomotor nerve is gone, so LR6, SO4 left, and they lead to down and out position of the eyeball. Another key point is fixed and dilated pupil. Now, when you are talking about the tongue area, very important is sensory supply of anterior two-third of tongue. The general sensation by lingual nerve and the taste sensation by chorda tympani nerve, in which you can see we are marked over here. Very much expected a question on chorda tympani. Supplying what? Taste sensation on anterior two-third of the tongue. Now, apart from this, when we are talking about the tongue, always we talk about the genioglossus muscle. The genioglossus muscle, safety muscle of the tongue, action is protrusion of the tongue. It is helping in the protrusion of the tongue. Very important. Genioglossus. And now when you say clinical aspect over here, when the hypoglossal nerve injury is there, what is a very important point? The tongue is deviated. Which side? The tongue is deviated to the same side of lesion. This is a point you should be knowing. Which side? Same side of the lesion. If the lesion is on the right side, the tongue is deviated towards the right side. So the tongue is deviated to the same side of the lesion. Now in the pharynx, these 2 points are very important for you. Killian's dehiscence present where? The Killian's dehiscence is in inferior constrictor muscle. Which 2 parts of inferior constrictor? It is between the thyropharyngeus and the cricopharyngeus. Okay, these are the 2 parts of the inferior constrictor only. So we say between these 2 parts of inferior constrictor, we have this Killian's dehiscence. Then another point is eustachian tube. It opens where? It opens in the nasopharynx. Which part of pharynx? In the nasopharynx. Okay, in the nasopharynx. Now, apart from this, when you are talking about the larynx area, in this, a very important point is that these 2 points, very important, and these 2 points are regarding the muscle. When you say cricothyroid, for the cricothyroid, what is the nerve supply? The nerve supply is external laryngeal nerve. Cricothyroid, nerve supply external laryngeal. And when you talk about the posterior cricoarytenoid, a very important point about this is what? A very important point about this is action. Action is what? Abduction of the vocal cords. It is helping in the abduction of the vocal cord. So these 2 points are very important for the larynx area. And now as you talk about the nasal cavity, for the little's area, very important, which 4 arteries are participating or they are anastomosing at the level of little's area. Now the 4 arteries which are anastomosing over here is greater palatine, superior labial, sphenopalatine and anterior ethmoidal. So all these 4 arteries are the one which are participating in the anastomosis in the little's area. Now in the nasal cavity only, in this we say that towards the lateral wall, we are having like the projections over here concha, and in between that we are having the areas. First of all, the sphenoethmoidal recess, then superior meatus, then middle meatus and inferior meatus. In these also we say the most important is what is the structure opening in sphenoethmoidal recess. And for the sphenoethmoidal recess, we say sphenoid sinus. Whenever you see any of the areas over here, only one area is starting with the word spheno. So that gives you a hint that it is for what? Sphenoid sinus. Okay, we are just taking a hint from it. Starts with spheno, so we say it is giving drainage to sphenoid sinus. And another very important is inferior meatus for what? Nasolacrimal duct. Okay, the gland for tears. Like, so whenever the tears are draining over here, the tears drain towards the lowermost side. That is inferior meatus for nasolacrimal duct for the tears. And when we are talking about the middle meatus, it is like having the majority of the sinuses opening over here. And for the middle meatus, very important, we say 2 structures located in the middle meatus is bulla ethmoidalis and another is hiatus semilunaris. These are the 2 structures which are present in the middle meatus. Now as we talk about the facial nerve, very important, 3 branches for the facial nerve. First branch, greater petrosal. Second, nerve to stapedius. Third, chorda tympani. All the three branches, they are given where? They are given in the middle ear. When you talk about this greater petrosal, it is at the level of, this branch is arising at the level, or it is located at the level of geniculate ganglion. So these are the three main branches: greater petrosal, now two stapedius, and then cauda tympani. They are arising in this order only. And now whenever we are talking about this facial nerve, for the facial nerve we say that it is passing through two foramens. From the cranial cavity, it first of all passes through internal equistic meatus, then it reaches the ear, and after that it passes through stylomastoid foramen, and then it comes out and reaches towards the face. So the stylomastoid foramen, and then the nerve comes out and reaches the face. So the facial nerve is passing through two foramens. Facial nerve passing through two foramens: internal equistic meatus and then the stylomastoid foramen. Now for the facial nerve, we say that this is one of the most repeated question at present, the clinical aspect question, in which the nerve lesions you should be knowing. Whenever you are talking about the nerve lesion, it can be upper motor neuron, it can be lower motor neuron. First of all, you should be knowing what we include in upper motor neuron. So in the upper motor neuron, we include what? Cerebrum and the fibers coming from the cerebrum. They are upper motor neuron. The facial nucleus and the facial nerve, they are what? They are lower motor neuron. So facial nucleus, facial nerve, they are lower motor neuron. And the boss of our body, brain, cerebrum, it is the upper motor neuron. So now for the upper motor neuron, we say what is the effect? The effect is contralateral side, lower half of the face is affected, and the forehead is spared. It is not affected. It is in the upper motor neuron lesion. In the low motor neuron lesion, which is a Bell's palsy, over here we say the ipsilateral half of the face is affected, which is affecting the forehead area also. So over here, the keyword for us is forehead. Whenever you are seeing a big long question, you just see what is happening to the forehead. Forehead is a keyword. If the forehead is affected, lower motor neuron. If they say forehead not affected, upper motor neuron. Quickly you say upper motor neuron. So forehead is a keyword over here. The forehead is paralyzed where? In the lower motor neuron. And whenever the forehead muscle is affected, it leads to the symptom over here, loss of transverse wrinkles on the forehead. You can see this is a normal side and this is a Bell's palsy side. Normal side, the transverse wrinkles are present, but when you see the Bell's palsy side, the loss of transverse wrinkles on the forehead. So this is the most important symptom due to forehead muscle. Another symptoms are like the person is not able to close the eyes. You can see inability to close the eyes, plus the angle of the mouth is tilted down on the affected side. Then other symptoms also are there, like accumulation of food, dribbling of saliva. And now apart from that, we say that sometimes in the question they also mention that the face is shifted where. So that what happens, the normal side, it pulls the face because the normal side muscles are okay. So whenever the normal side is okay, whenever we say this is the normal side, if we say this is a normal side, so what happens, because the muscles are normal over here, so they will pull the face towards itself. So by sometimes it is mentioned in the question that the face is pulled to one side. So the normal side pulls the face towards itself. So when we are talking about the upper motor, lower motor neuron, first of all, you should be knowing these points. Then the forehead muscle is a keyword. When the forehead muscle is affected, loss of transverse wrinkles on the forehead. What are the other symptoms? Another main symptom is inability to close the eyes, and as well as the angle of the mouth is tilted down on the same side of the lesion. This is the important point. Now, as we talk about the sagittal section, now again you have come to the sections over here. So as I said, section very important, very important, all the sections. So this section is also the sagittal section of head and neck, and we say in this already the question has come on genioglossus and another question has come on epiglottis. Right. Then apart from this, what are the other very important landmark or you can say expected landmarks over here are what? The expected landmark over here is this one. This is a location of sphenoid sinus. Just above that, whatever U-shaped depression you see is the sella turcica. And if you see any sinus towards the front, over here, frontal sinus. This is the hard palate, behind it, soft palate. At the chin, the bone is mandible. Behind it, hide bone. Towards the posterior side vertebral column, you say that this small section C1, bigger section C2. In the nasopharynx, if you see any opening, eustachian tube opening. This area is the area of the larynx. So all these landmarks you should be able to tell, and as I told you, one of the expected new question is sphenoid sinus or sella turcica, which you should be able to identify. Even if the X-ray of the same image is given, you should be able to identify. Exactly the same location will be there. Now after that, for the cranial nerves, we say very very important which cranial nerves carry parasympathetic fibers. It is 3, 7, 9, 10. Then we say the only cranial nerve which is arising from where dorsal aspect of the brainstem, posterior aspect of the brainstem. Only one cranial nerve arises from there, which is the trochlear nerve. The cranial nerve involved in increased intracranial pressure, abducen nerve. Among these three, also we say a very very highly expected question is this parasympathetic fibers 3, 7, 9, 10. Now, as you talk about the other points over here, a very, very like a question which is now at present very important is which cranial nerve is present at pontomedullary junction. Now, this is what cranial nerve 6, 7, 8. Okay, this is the cranial nerve 6, 7, 8. Then, apart from this, we say lingual nerve is related to teeth. Only one nerve is there which we say in relation to the teeth, and that specifically we say third molar tooth. Related to which nerve? It is related to the lingual nerve. Okay, it is related to the lingual nerve. So over here we have done the head and neck revision, and now what we will do, we will quickly take a 15-minute break and then we will revise the rest of the portion. Okay, so we will be taking a very short break and then we will revise the rest of the portion. Okay, so we are back from the break and we have discussed, we have revised till head and neck. Okay, the next we are going to revise what? We are going to revise neuroanatomy. Now, whenever you are revising anatomy, I really recommend to you that you open the video in front of you and then along with that you revise, so that you will be understanding that which are the very ultra important points which you cannot miss, and you have to ensure that you know those points very well, and what are the images which are very important for image based question. So it will be really helping you whenever you will be revising the anatomy portion. And the thing is that I know that during this time it is very tough. You are doing so many subjects together. But the thing is that you have to be calm by your mind. ठीक है, दिमाग को शांत रखना है, कूल रहना है, दिमाग को शांत रखना है और भगवान पे विश्वास रखना है कि सब कुछ बहुत अच्छा होगा. You have to give your hard work. You should yourself know that I'm putting so much of my hard work. If you know that thing, if you realize that thing, that means you are doing well. So you have to put your own hard work, and then nothing can stop. Nothing can stop you from reaching to that success. So you will definitely win. Don't worry. See, what happens, sometimes we face failures also, but the failures does not mean that you cannot win. The failures are only to learn. We learn from our mistakes so that the success is much better. So there are like many of the students are there who are freshers, many of the students are there who are giving this exam and they have given the exam earlier also. So you should never doubt yourself. Never have any doubts on yourself. Learn from your mistakes and you're going to get a success which will be much better success. So just don't worry, don't think about past, just think about present, just think about future. So you have to plan for today and you have to plan for tomorrow. That's it. Okay, no past. Plan for today, plan for tomorrow, and whenever like you are in like sitting, don't you don't give any importance to any negative thought which is coming to you. If you are not studying, keep your mind blank. Don't put any negative mind in that. If any negative thoughts are coming, you just wash it off. Tell the negative thoughts that I'm not going to think about you, or I'm not going to give importance to you. I'm going to ignore you. So leave all the negative thoughts. Don't think about the past. Just think today. Plan for tomorrow. Follow the schedule. And as I told you, be regular. The revision is key to success. And if any point which is you are not able to remember, then repeat. You have to repeat that point. So let us start with this neuroanatomy portion. And in this neuroanatomy, in the lateral view, we say that very important is this sulcus. You should be able to identify the sulcus, which is a lateral sulcus, also known as Sylvian fissure. Another is the central sulcus, which is also known as Rolando sulcus. Now, when you are talking about this medial side, so this is a sagittal section, a very important section, which is a highly expected question. And actually, the question which is highly expected is this radiograph, which is a sagittal section. So when you see this sagittal section, then on the lower side, you should be able to identify the parts of the brainstem: midbrain, pons, medulla. This is a cerebellum, spinal cord. In between the pons and cerebellum, you have which ventricle? Yes, it is the fourth ventricle. Then let us come to the upper side of image. This C-shaped structure over here, this is the corpus callosum. Any projection you see from the corpus callosum is fornix. Below the fornix, thalamus. Below it, hypothalamus. Below it, pituitary gland. These are the main structures over here which you should be able to identify. Now, what are the other structures? The other structures are, if they put the arrow between the corpus callosum and the fornix, this is the location of lateral ventricle. If they put the arrow between the pituitary gland and midbrain, a round structure over here, this is the mammillary body. If they put the arrow on the posterior side, just below the corpus callosum, this is a location for the pineal body. Okay, so these are the other structures which you should be able to identify in the image. And if you are able to identify this image, then you can very easily answer this portion. This is exactly the same. If you see this image, it is exactly the same image, exactly the same structures you can identify over here also. So now sagittal section, very, very important. One of the expected question over here. Now, spinal cord ends at what level? In the adults, L1. Which border? It is a lower border. In the newborns, L3, upper border. This is for the spinal cord. The spinal cord is ending at this level. So for the newborns, it is the upper border. For the adults, it is lower border. And when you say what about the other structures, so you say dura, arachnoid, subdural space, subarachnoid space. Very important, subarachnoid space ends where S2, again it is lower border. One more structure is over here, pia mater, which we have not mentioned. For the pia mater, we basically say it extends as phylum terminal, and the phylum terminal is attached to the lowermost part of vertebral column, which is the coccyx. So phylum terminal, it is the extension of the pia mater. Now, after this, when we talk about the corpus callosum, you should be aware that what are the parts of corpus callosum. Starting from the anterior side is rostrum, genu, body, splenium. And what are the other components? The names of the other components of corpus callosum is forceps minor. It is a forceps minor, forceps major, and tapetum. These are the other names of the components of corpus callosum. So you should be aware of the names of the components of corpus callosum, and as well as in this image, these 4 parts. This image you should be knowing. Now, when we are talking about the white matter, the white matter fibers are of 3 types. One is association in the same hemisphere. And whenever we are talking about the association fibers, examples are all fasciculus. All fasciculus over here, and then we say cingulum. The cingulum we have memorized by this word single. We said single, cingulum. Rhyming is there, single, cingulum. So single cingulum is, of course, in one hemisphere. Along with that, all fasciculus. Whatever fibers are having the name fasciculus, they are included in the association. They are in the same hemisphere. And when I say commisural, the commisural, they connect the right and the left hemisphere. So these are the connecting fibers. And in the connecting fibers, we say the most important is the corpus callosum, which is the largest commisural fiber. Other examples, if you see, all are having the word commissure, commissure, commissure. And when you say the last one, projection fibers, so projection fibers which project the information from the brain to the other parts of from the cerebrum to the other part of the brain. So projecting fibers are corona radiata, internal capsule, tracts. These are the other fibers. So when you see in this image, we have already mentioned this is the corona radiata, internal capsule, and after that this is the tracts. So these are what? These are the white matter fibers. Now for the functional areas, you should be like memorizing this image. You should be knowing this image. So try to practice this image 2-3 times and you will be able to remember. When you say central sulcus, in front of it motor area, behind it sensory. Occipital lobe, visual area. Below the lateral sulcus, auditory area. Wernicke's, sensory speech area. On the anterior side, Broca's area. The Broca's motor speech area. All these functional areas where on the lateral aspect, this is a lateral view, this is a lateral aspect of the cerebrum. On the medial aspect of cerebrum, you have only one small area which is paracentral lobule. It is a paracentral lobule. So along with the central sulcus, some part of motor and sensory area, it comes on the medial side, which is known as paracentral lobule. So this image you should be knowing, and on the medial side only the paracentral lobule. Then for the function areas, the area number is very important. Motor area number 4, sensory area number 312. And when you say paracentral lobule, one of the expected question over here, this has been asked this year, but this is why I've written expected, one of the most important which can be repeated. It can be repeated as such. So one of the very important question which can be repeated. Paracentral lobule represents which area of body? It represents perineum and lower limb. Very easy way to remember. We say P for paracentral, P for perineum, L for lobule, L for lower limb. So paracentral lobule represents which? Perineum and the lower limb. Now, after that, the other functional areas is visual area 17, 18, 19, auditory area 41, 42, and now very, very important, speech areas. Speech area, again, one of the expected question for you. Any of the question can come from speech area. Wernicke sensory is area number 22, and the Broca motor is area number 44, 45. Both the areas connected by arcuate fasciculus. If there is lesion in the Wernicke's area, it leads to fluent aphasia because the comprehension or the understanding is affected. So if the person is not able to understand, so he will speak anything he will speak. He will speak fluently, but whatever he speaks is meaningless. It is not up to the mark. Like you are asking, whatever question you are asking, if you ask any question, he will speak fluently, but he will not speak according to your question. He will speak something else, and you will say, "Oh my God, what a person you are! You are like meaningless." So meaningless words, and he speaks fluently, so known as fluent aphasia. When you compare it with the Broca's area lesion, then we say it is affluent aphasia. In this, the person is not able to speak. The Broca's area is for the actual speaking, and the person is not able to speak in this lesion. He is only able to speak one or two words. If you ask him some question, he will be able to answer only in one or two words. That's it. So we say it is affluent aphasia. Now, over here for the arterial supply, we mainly say that the main artery for lateral surface is middle cerebral, and this is the supply towards the lateral surface. Majority of area by middle cerebral, on the posterior side by posterior cerebral, and a very small strip towards the upper side by anterior cerebral. And therefore, we say that occipital lobe or visual area. The blood supply for the visual area is what? It is a posterior cerebral artery. It is a posterior cerebral artery. So this is for cerebrum. Now next we say, yes, a very, very important section over here, the transverse section. The transverse section, or you take the coronal section, all the structures will remain the same, but mainly they ask you, this transverse section has been asked 4-5 times, and now also it is expected that they can ask you. It is one of the very repeated question and one of the expected question over here. So when we are talking about the transverse section, first of all, you should be able to identify the nucleus, lentiform triangular nucleus from the lateral side, towards the midline, thalamus, and caudate nucleus. The thalamus is a big oval nucleus towards the posterior side, and caudate is a small nucleus on the anterior side. And when we talk about this area between the nucleus, this V-shaped area, this is known as internal capsule. These are the most important landmarks. Now after that we say, between the thalamus, whatever space you see in the midline is third ventricle. Along the caudate nucleus, if you see some triangular area, this is what? Lateral ventricle. And any other triangular area you see, like for example over here on the posterior side we see some triangular area, that is also lateral ventricle. Then on the posterior side of the image, on the most posterior side, a triangular area is there, which is superior sagittal venous sinus. And as we go slightly in front of it, what you see, some roundish area is there, which is what? Straight sinus. Yeah. So superior sagittal sinus, and this is a straight sinus. Now after that we say, if you see from the lateral side, a sulcus is there from the lateral side, and similarly a sulcus from here also. This one is what? This is the lateral sulcus. This is the lateral sulcus from lateral side, and the area which is around this lateral sulcus is given the term as what? It is given the term as insula. So all these structures you should be able to identify in this image. Very, very important, and one of the expected question for you. All these landmarks you should be able to identify. Then a very basic thing, you should be knowing that diencephalon, the thalamus comes in diencephalon. And when you say caudate and lentiform, they come under basal ganglia. In the basal ganglia, you have caudate, putamen, globus pallidus. These two are known as lentiform, and all these three together are known as corpus stratum. Right? And we have just mentioned that when we are talking about the nucleus over here, from the lateral side, on the lateral side, the triangular nucleus present is lentiform. In the lentiform, globus pallidus is on the inner side, and putamen is on the outer side. Then towards the medial side, we already said that this is big oval nucleus is thalamus. Anterior side, you have the caudate. Between the three nucleus, the V-shaped area is the internal capsule. Now, apart from this, the other two structures which you should be knowing in this image is that if you see lentiform nucleus, as you go outer to it, irregular area is present over here, which is known as the claustrum. And between the claustrum and lentiform, this orange colored area which is present over here is given the term as external capsule. So these you should be knowing for any image based question. Right? So very, very important, the sagittal section and the transverse section of the brain. Very much. After this, we talk about the landmarks which are in the brainstem. The most important landmarks for image based question in the brainstem is one is the pyramid, where you can see it is in the medulla near the midline. So pyramid near the midline, lateral to it olive. Pyramid is actually due to deep to it pyramidal tract, and when you say olive, deep to it inferior olivary nucleus. So main is what? Main is pyramid. Very, very important, near the midline, whatever prominence you see in the medulla is pyramid. So again and again I am saying pyramid, very important. So you should be able to identify pyramid. And then another landmark which is very important in the brainstem is facial colliculus, where? Posterior side. So when you see this posterior view, in the posterior view, in the center, if the arrow is put in the center of the image, this is a round prominence known as facial colliculus. What is important in this is that the facial colliculus present where? In the pons, in the middle area. So it is the pons. And we say what is lying deep to it? So yes, lying deep to it is a nerve and a nucleus. The nerve is facial nerve, the nucleus is abducent nucleus, and you answer according to the options. If the options is nerve, answer is facial nerve. If the options are having nucleus, answer is abducent nucleus. And over here, if by chance both are given in the options, then first you mark facial nerve. The facial nerve is always the best answer. Okay, first is the best answer, facial nerve. Now, when you talk about the cerebellum, for the cerebellum, we say each lobe of the cerebellum is divided into three parts. This is each hemisphere. Each hemisphere is divided into three lobes. Anterior, posterior, and a very important, we say flocculonodular lobe. This you should be knowing that this word we are using, flocculonodular lobe, is for what? It is for cerebellum. Now, what is the characteristic cell of the cerebellum? Yes, the characteristic cell of the cerebellum is Purkinje cell. And now you say deep cerebellar nuclei, ABCD. You remember ABCD? Yes, ABCD, D, E, F, G, D, E, F, G. So these are the nucleus, dentate, emboliform, globose, fastigial. Okay, so these are the D, E, F, G. These are the nucleus which are present in the deeper aspect, deep cerebellar nuclei, dentate, emboliform, fastigial, globose. Four deep nucleus, D, E, F, G. Now, when we are talking about this cerebellum, we say final output from the cerebellum or the final efferent from the cerebellum are from what? Yes, they are from deep cerebellar nuclei. They are from the deep cerebellar nuclei. Now, for the ventricles, very, very important, you should be knowing the location of third ventricle and the fourth. Third is where? Between the two thalamus, or you say between the diencephalon, between the two diencephalon, right and left. And the fourth ventricle between the pons and cerebellum. If you ask me image, that which image is more important in the ventricle, this is the image which is important for the ventricle. If they are, by chance ask you in the image. So in this image, the C-shaped structure is lateral ventricle. This one also and this one also. These both are lateral ventricle. In the midline, this is a third ventricle. This diamond-shaped area over here, this is the fourth ventricle. The connection between the lateral and the third ventricle is this interventricular foramen of Monro. And this connection between the third and the fourth ventricle is cerebral aqueduct of Sylvius. So this image you should be knowing. And when we are talking about this whole pathway, the whole pathway is formation by choroid plexus of lateral ventricle. Then it is passing through these foramens and it is running in the third, fourth ventricle and then finally to the subarachnoid space. So whenever you are talking about these connections over here, you should be knowing the connections at the location. Lateral ventricle connected to third by interventricular foramen of Monro. Third is connected to fourth ventricle by cerebral aqueduct of Sylvius, and the fourth ventricle from here by foramen of Magendie and Luschka, the CSF goes to subarachnoid space. In the subarachnoid space, the final absorption by what? By arachnoid granulations or villi. And finally, the CSF is goes into superior sagittal sinus. Now, this is clinically important. Like if they give you this condition, hydrocephalus, they can ask you that the hydrocephalus, the patient has come with hydrocephalus, and there is an obstruction in the flow of the CSF. And if, for example, if they mention you that there is obstruction between third and fourth ventricle, so what is the location of obstruction? So the answer will be cerebral aqueduct of Sylvius. So this flow chart over here can be asked as a clinical question. So you should be knowing it well so that you are able to solve any clinical question also. Now for the arterial supply. For the arterial supply, we say that the main arteries over here is what? The main arteries is the vertebral artery, pica. It gives the branch pica. Another important branch, ASA, anterior spinal. So we remember like this pica. Pica is what? If you remember pica from vertebral, pica is posterior inferior cerebellar artery. So first of all, you remember pica. Pica is from vertebral plus anterior spinal also. And when we are talking about anterior spinal, we know finally we have one anterior spinal. So the spinal cord gets only one anterior spinal, two posterior spinal. And the anterior spinal is the one which supplies the anterior two-thirds of the spinal cord. And whenever we are memorizing this supply to the brain, we say anterior side occupied by internal carotid, posterior side is mainly supplied by vertebral and basal. So very important, anterior side area by internal carotid, posterior side area over here by vertebral and basal. This is just a funda to memorize the main arteries. Now, what is we are mainly memorizing is pica. Again and again, I am saying pica, pica, pica. Pica is vertebral artery. So, pica is from vertebral artery, then ASA also from vertebral artery. Then, apart from this, now we say ICA. Opposite branch, ICA, anterior inferior cerebellar artery. Now, this is arising from where? This is arising from the basilar artery. So, first you memorize pica from vertebral, opposite of this ICA from basilar. And now we say, when we talk about internal carotid, very important artery over here is anterior choroidal artery. The anterior choroidal artery is a branch from internal carotid. And as I told you, internal carotid is on the anterior side. So everything you will see, anterior part of cerebrum, middle part of cerebrum and eyes. All this area is supplied by internal carotid. So that is why written over here, anterior cerebral artery, middle cerebral artery, ophthalmic artery. Okay, but main artery over here we say anterior choroidal. So pica, vertebral, ICA, basilar, anterior choroidal, internal carotid. Right. Now the circular villus we say it is between what? It is between the internal carotid and basilar artery. And the branches which are participating over here, we remembered how? Yes, anteriors, posterior. Two anterior, two posterior. Anteriors and posterior. So two anterior, two posterior, anterior cerebral, anterior communicating, posterior cerebral, posterior communicating. Same words are there, cerebral, cerebral, communicating, communicating. So what we remember over here, two anterior, two posterior. So this is a circular villus, and when you are seeing in the image, very, very important, like this is one of the expected image for us, that this image can come, and that also most important landmark are these two. In the vertebral artery, any branch on the lateral side is pica, any branch on the medial side is anterior spinal artery. Okay, these are the two very important landmarks over here. Then this is a whole arterial network in which vertebral artery on the lower side, basilar artery over here, and internal carotid on the upper side over here. And in between this internal carotid and basilar, you are having the circle of Willis, the circular anastomosis, which is present over here. And you can see this is a whole image. And in this image, as I told you, very, very important to identify pica and ASA. Now, when you are talking about why these two, because these two are associated with syndrome. Pica, if it is occluded, it leads to lateral medullary syndrome, also known as Wallenberg syndrome. And anterior spinal artery, when it is occluded, it leads to medial medullary syndrome. Fine. Now, if by chance, like somehow I've seen that some questions are there which are mentioning both vertebral and the pica, in that case, you will give more preference to vertebral artery than pica. If by chance they are both mentioned, then you will give preference to vertebral. Otherwise, always the answer is a pica only. So these are two very important arteries. Very, very important over here. The clinical aspect in which we are highly expecting this question. If a new question comes, it can come on Wallenberg syndrome. And when you see the Wallenberg syndrome, multiple symptoms, vague symptoms, multiple symptom along with one specific symptom, which is contralateral loss of pain and temperature. Okay, which is a contralateral loss of pain and temperature. So you remember like multiple symptoms, lung state is there, and along with that you say contralateral loss of pain and temperature. So over here we say this is the Wallenberg syndrome, also known as lateral medullary. When you say medial medullary syndrome, a specific symptom, if by chance it comes, then the specific key point over here is a cranial nerve 12 involvement. It is a cranial nerve 12 involvement over here for the medial medullary. Now, whenever you are saying this contralateral loss of pain and temperature, we remember by this PTO. PTO is what? P is pain, T is temperature, and O means opposite. So we say like multiple vague symptoms are there along with PTO. Pain, temperature, opposite side. The pain temperature is lost on opposite side. Okay, multiple symptoms with pain and temperature lost on opposite side. Now next, like this is a clinical aspect very important. Another clinical aspect very important is lumbar puncture and epidural. For the lumbar puncture, the three ligaments which are pierced, very, very important. Supraspinous, interspinous, ligamentum flavum. Order is outer to inner side. Then after that it pierces dura and arachnoid and finally reaches the subarachnoid space. So very, very important is the three ligaments pierced. And when you say epidural space or epidural procedures, then we say we pierce all these structures but till ligamentum flavum. The last structure to be pierced is ligamentum flavum. So we pierce from 1 to 5. We are piercing only from 1 to 5. So these are another clinical aspect which is very, very important over here in the neuro. Now, if you see this image, in this image, you should be able to identify the location of dorsal column, which is on the posterior side. And now, as you talk about the tracts, in the tracts, we say for ascending tracts, sensations which are carried by the tract. The dorsal column, what is the sensation carried? Fine touch, vibration, conscious proprioception. Also, we name it as joint sense. These are the three main sensations which are carried. Then we say that it is having two components, gracilis and cuneatus. Gracilis, we remember gracilis for ground. Ground where? Ground is where? Ground is on the lower side. So we say fibers from the lower part of the body form gracilis, fasciculus gracilis. And the fibers from upper part of body, they form cuneatus. And because we are having this word fasciculus and cuneatus and gracilis, so that is why the same name nucleus, gracile nucleus, cuneate nucleus. They are the second order neuron over here. So we remember the same thing, gracilis, gracile, cuneatus, cuneate. So whenever this nucleus is mentioned, this is the nucleus for dorsal column, second order neuron. The third order neuron over here we say very important is what? VPL. We remember over here in the thalamus it is VPL. If you remember VPL, you are able to expand it ventral posterior lateral. So we just remember VPL. It is VPL. So over here we memorize the word gracilis cuneatus. According to that you can answer the nucleus. And over here we memorized VPL. Right. So the sensations carried very, very important in the dorsal column. Now when you say spinothalamic, in that also the sensation carried is very important. Anterior spinothalamic carries crude touch pressure. Lateral spinothalamic carries pain and temperature. Right. Now in this we say for the crossing of fibers, a very, very important aspect over here is crossing of fibers. When I'm talking about the crossing of fibers, we have written them together. In the crossing of fibers, the dorsal column, corticospinal, both of them they cross at medulla. Spinothalamic crosses at spinal cord. You should be knowing that which column, which tract is crossing where. And now to make it a bit easier, we say whatever tract is starting with the word spino. So we take a hint from that, whatever tract is starting by the word spino, that tract is going to cross at spinal cord. So spinothalamic crosses at spinal cord, and the rest of the two tracts are at medulla. So we say dorsal column, corticospinal, you are towards the medulla. Now, when you say descending tracts, in the descending tract we mainly say is the pyramidal or corticospinal tract, which is actually responsible for all the skilled voluntary movement, and the rest of the tracts are included in extrapyramidal, which are for automatic involuntary movements. In the extrapyramidal, main is rubrospinal. So one is the corticospinal word, which you should be knowing. The corticospinal or the pyramidal tract is the main. It is the main in the descent, which is for the skilled voluntary movement. And we just mentioned it crosses at the medulla, and at the specific location we say lower medulla. Now, a clinical aspect which is associated over here is Brown-Séquard syndrome. In the Brown-Séquard syndrome, you have specific 3 symptoms. There's a combination of 3 symptoms. And if you see, symptoms are ipsilateral, and again one symptom is there which is contralateral. And the contralateral we say again it is what? It is PTO, pain, temperature, opposite side. But over here PTO is associated by 2 ipsilateral symptoms. 2 specific ipsilateral. There are no multiple symptoms over here, only 2 specific symptoms, which is ipsilateral hemiplegia and ipsilateral loss of fine touch. So now the PTO is associated by 2 symptoms extra only, and that is these 2 symptoms. And now we say the combination of 3 symptoms. So always remember there is a combination of 3 symptoms over here only 3 symptoms. Brown-Séquard syndrome. That is a Brown-Séquard syndrome. And another syndrome which you should be knowing is the Weber syndrome. The keyword over here is cranial nerve 3 involvement. So cranial nerve 3 involvement is the keyword. Ipsilateral cranial nerve 3 involvement, along with that contralateral hemiplegia. This is for the Webers. So now in this neuroanatomy, first of all, very important is whatever sections we have discussed, and another thing is whatever clinical aspect we have discussed. In the clinical aspect, lumbar puncture, epidural procedure, medial medullary syndrome, lateral medullary syndrome, Brown-Séquard syndrome, Weber syndrome. Very, very important. So whenever you are studying neuroanatomy, please ensure first of all you are clear with these points, and then you can memorize the other points. Now when you go towards the lower limb, in this highest point of iliac crest, L4 level. Another important point, mid-inguinal point. Because this is important, why? Because this is the point in which the students are confused. What is this mid-inguinal point? This mid-inguinal point is a midpoint between ASIS and pubic symphysis. ASIS and pubic symphysis. And a very important structure is located over here, which is the femoral artery. And at the same location, you can feel the pulsation of this artery. Femoral artery pulsation can be felt at mid-inguinal point. Okay. Now, apart from this image is very, very important for you. For any image-based question, all the structures which are mentioned over here, you should be able to identify. Pubic symphysis, foramen is obturator foramen. Over here, this foramen is obturator foramen. Then when you say this convexity over here for the hip bone, this convexity is iliac crest, anterior-most landmark ASIS. Towards the pubis, we say one landmark over here is pubic tubercle, a ligament which extends between the two. This ligament is inguinal ligament. All these landmarks which we have mentioned over here, all these landmarks are important for you. You should be able to identify in the image-based question. Then in the femur, image-based question, in the image on the upper side, you should be able to identify this is a location of greater trochanter, this is a lesser trochanter, and what are the muscles attached to it. Now for the lesser trochanter, we first of all say muscles attached to it is iliopsoas. Okay, iliopsoas. Iliopsoas is what? Iliacus and psoas major. So like if you remember iliopsoas, you can answer both the muscles, iliacus and psoas major. Common action done is flexion. Both the muscles they help in the flexion. Then another is greater trochanter. Greater, so bigger, important muscles, gluteal muscles, gluteus medius, minimus. The gluteus medius and minimus, both the muscles, they are doing what action? Both of them, they contribute in abduction at the hip joint. So now, This can be asked as a image based question. They can put the arrow on any of the landmark like this, and they can say what is the muscle which is attached to this landmark, or they can say what is the action done by the muscles attached to this landmark. So you can answer now any of the question according to this portion over here. We have discussed the muscles attached and the common action done by those muscles. Now, as you talk about the foot over here, you should be like having this orientation of the bones over here. Whenever you identify the bone, talus. In front of talus, slightly curved bone is navicular. In front of that, 3 cuneiform. When you identify calcaneum, which is the heel bone, in front of it is the cuboid. So when you see the superior view, this is superior view is the most important. So you say talus. In front of it, curved bone navicular. In front of it, 3 cuneiforms. So these bones are always present together in a line. Then you say calcaneum. This is a calcaneum. In front of it, cuboid. So this is present in a line, calcaneum and cuboid. And then another thing we say that when you see the navicular bone over here, it is towards which side of the image? It is towards the medial side of the image. So if by chance you are confused, then always confirm by this that the navicular is on which side? It is on medial side. And if it is on the medial side in the image, 100% confirm it is navicular. Now, for the structures passing through greater and the lesser sciatic foramen, we say which structures pass through both greater and the lesser sciatic foramen. For that, we say pin. What is this pin? Pin is what? Pin is this pudendal nerve, internal pudendal vessels, nerve to obturator internus. So pin is these 3 structures passing through both the foramen. Now after that, in the lower limb, the root values which are important for us is sciatic nerve, root value L4, L5, S1, S2, S3. For the pudendal nerve, it is S2, S3, S4. Okay, S2, S3, S4. These are the 2 root values which are important for us. Now, as we come to the thigh region, first of all, we remember which is the nerve for each region. The thigh is having anterior posterior compartment plus one more compartment on the medial side. Anterior posterior will always remain important. So we say anterior side femoral nerve, posterior side sciatic nerve, and the medial side is obturator nerve. So first of all, you memorize this. Only one nerve for each compartment. It will become easier for you to answer. Femoral nerve, anterior side. Sciatic nerve, posterior side. Medial side, obturator nerve. And now next we say, if these are the nerves for each compartment, so whatever muscles are present in each compartment, they are supplied by this nerve. Anterior compartment, mainly we are having quadriceps. Quadriceps plus sartorius. These are 2 main muscles. So anterior side we have quadriceps, sartorius supplied by femoral. Posterior side main muscle group is hamstrings. So they will be supplied by sciatic. And medial side we mainly have the adductors. So they will be supplied by obturator nerve. So we remember over here that which is the main nerve of each compartment, which are the main muscles of each compartment, and what is the like common action which are done by all. So if I am, first of all, we are memorizing the nerves for each compartment. Anterior compartment you have quadriceps, sartorius. Posterior compartment mainly hamstrings. Medial compartment mainly adductors. And now when you talk about the action over here, so the quadriceps, they have a common action, extension at the knee joint. So for the quadriceps, for the anterior side muscle quadriceps, the common action is extension at the knee joint. Hamstring on the posterior side, common action is flexion at the knee joint. Adductors on the medial side, the common action is adduction. As the name suggests, adductor, adduction. So like in the lower limb, what we do is that first of all, we memorize the nerve of that compartment. Then according to that muscles, you can tell the muscles, the main group over here in the thigh, the main groups are there. And then the common action done by that. So it makes it easier for us to memorize the thigh area. Okay, so again, these are the nerves. Muscles we have just mentioned. For the muscles, we said quadricep, main action is, common action is extension at knee joint. Hamstring, flexion at knee joint. And for the adductors, it is adduction at the hip joint. Now, apart from this, we should be knowing that what is the root value for femoral nerve. For the femoral nerve, L2, L3, L4, and specifically which division? It is the posterior divisions of L2, L3, L4. Okay. So the root value we have memorized for sciatic nerve, femoral nerve, pudendal nerve. These three nerves are very important for root values. Now, this is the same thing we have mentioned in the anterior compartment. Medial compartment, mainly the adductors are there, and we already said obturator nerve is there having the same root value. And when we say common action, the common action is adduction. The common action is adduction. Now on the anterior side, we say femoral triangle is there, and now you should be knowing that what are the boundaries of the femoral triangle. Now when you are talking about the boundaries over here, medial side always adductor, always adductor. Medial side is always adductor. So medial side you will be always having adductor, and it is what adductor longus. Lateral side sartorius. Towards the superior aspect inguinal ligament. So we say medial side is adductor longus, lateral side is sartorius, and towards the superior side or base of the triangle is inguinal ligament. Sometimes they ask you in detail that which border of the muscle. So it is a medial border of both the muscles. Okay, there's a medial border of both the muscles. Then apart from this, for the floor, from medial to lateral, we are having four muscles: adductor longus, pectineus, psoas major, iliacus. Four muscles from medial to lateral. These are the four muscles from medial to lateral. And when you are talking about the contents, it is like, what are the main contents over here? The main contents we remember like this: L-van. L-van, lymph node, vein, artery, nerve. From where? Medial to the lateral side. It is from medial to lateral side. Lymph node is deep inguinal. So what we remember over here? L-van. L-van from medial to lateral side. It is L-van from medial to the lateral side. So again you can see over here, from medial to lateral side it is L-van. And now specifically we say these three structures are covered by femoral sheath. What three structure? LVA. LVA. They are covered by femoral sheath. So when we are saying LVA, they are covered by femoral sheath. Now in the femoral sheath, the most important compartment, medial compartment. Medial compartment known as femoral canal. And what is the content of this? The content is lymph node. The content is lymph node. Mainly what? It is a lymph node of Plockett or Rosenmuller. So very, very important over here, femoral canal. Now next, as we talk about the adductor canal. In the adductor canal, what we actually mainly remember is boundaries. In that also medial and the lateral boundary. These are the two main things we remember. And in this also we remember first medial boundary, which is easier to memorize. Medial boundary first. The medial is formed by always, as I said, adductors. You have adductors on the medial side, you know. So medial boundary by adductor longus and the lateral boundary by vastus medialis. So first you remember the medial boundary, it is by adductor longus, and then you memorize that the lateral boundary is by vastus medialis. Okay. Now, after that we memorize these two clinical points over here. One clinical point is the nerve for cremasteric reflex is genitofemoral nerve, because it is afferent as well as efferent. Afferent, it is carrying the sensation from the skin. Efferent, it is supplying the cremaster muscle. So we basically say that genitofemoral nerve is the nerve of cremasteric reflex. This is one of the clinical aspect over here. Another clinical aspect is if there is compression of the lateral cutaneous nerve of thigh, it will lead to meralgia paresthetica. And just think that this nerve is compressed. What will be the symptom? The symptom will be sensory symptom where towards the skin of lateral aspect of thigh. Okay, towards the skin of the lateral aspect of thigh. The sensory symptoms, the pain, mainly the tingling, numbness can be there. Sometimes they can also present as pain on the lateral aspect of the thigh. So these two clinical symptoms, the two clinical aspects, one is the nerve of cremasteric reflex, genitofemoral nerve. Another is meralgia paresthetica, compression of what? Lateral cutaneous nerve of thigh. Now, as you talk about the gluteal region, we say a very important muscle is their maximus. So when you say maximus, a very important clinical aspect associated with that is intramuscular injection. Which quadrant? Yes, upper and outer quadrant. And now when we are talking about this muscle, nerve supply. Maximus is by inferior gluteal nerve. Its action is extension at the hip joint. When you say medius and minimus, they are supplied by superior gluteal nerve and the action is abduction. These points are very, very important. So you say maximus, inferior gluteal, medius, minimus, superior gluteal. Maximus action is extension. And the medius, minimus, which are always together, they are having the action what? Abduction at the hip joint. So these two are very, very important. And then we say the clinical aspect associated with it. If the superior gluteal nerve injury is there, then which muscles are gone? Yes, medius minimus are gone. And when the medius minimus is gone, we say the Trendelenburg sign is positive. This is the image showing the Trendelenburg sign. This is a normal person. When you stand on one foot, then the same side muscles, the superior gluteal nerve and the same side medius and minimus, they act in such a way that they lift the pelvis. This is a normal person. When the person is having superior gluteal nerve injury, then the same side muscles, medius and minimus, are paralyzed. So if I am saying that this medius and minimus are paralyzed over here, and now the patient, when he keeps this foot on the ground, these muscles are not able to act and the pelvis will fall down. The pelvis falls down and we say pelvis falls on opposite side. So for the superior gluteal nerve injury, a very, very important question which is asked is pelvis drops or it falls on which side? It falls on opposite. It falls on opposite side. So for the superior gluteal nerve injury, remember it falls on opposite side. The Trendelenburg sign is positive. Due to that, lurching gait is present. Right? So this is very, very important over here. Superior gluteal nerve injury, another clinical aspect over here. If by chance both side nerve injury is there, then we say it is the waddling gait. This is the same thing which we already discussed. Posterior side thigh nerve is sciatic. Main muscle is hamstring. Main action, common action is flexion at the knee joint. Now, when you're talking about the popliteal fossa, a main event which is occurring in the popliteal fossa is division of the sciatic nerve into tibial and the common peroneal. So when you see the sciatic nerve over here reaches the popliteal fossa, divides into tibial and the sciatic nerve, tibial and the common peroneal nerve. So therefore, these three nerves are present where in the popliteal fossa. Now, when you talk about the knee joint, mainly these clinical points are very, very important for you. In this, we say meniscus. First thing, meniscus. When you see the meniscus, what cartilage? Fibrocartilage. It is fibro. There's a fibro cartilage. Then, what is the clinical aspect? Which meniscus is more prone to injury? So, we say it is a medial meniscus which is more prone to injury. This is one clinical aspect. Another clinical aspect about cruciate ligament. What is the function of the cruciate ligament? It provides anterior posterior stability. Anterior posterior stability means it is preventing any anterior and the posterior dislocations at the knee joint. So it prevents any dislocations. And when we are talking about the dislocations, we remember for anterior cruciate ligament. If we know about anterior cruciate ligament, posterior cruciate is just opposite. So we memorize for anterior cruciate ligament only that anterior cruciate ligament prevents what? So the main point is it prevents anterior dislocation of tibia. So we need to remember only this, and we know very well what and we said and what was that? Anterior dislocation of tibia. So it prevents anterior dislocation of tibia. And if it is the anterior dislocation of tibia, the rest of the portion we say in this sentence is posterior dislocation of femur. So the main point in the anterior cruciate ligament is it prevents anterior dislocation of tibia. Then locking and unlocking, very important. Locking is by quadriceps, unlocking is by popliteus. Very important that which muscles are helping in that. Now, as you come to this page, I already told you that this page is very important whenever you are doing any question on the leg area. So first of all, you should be knowing that sciatic nerve divides into the tibial and the common peroneal. Tibial is a nerve for anterior compartment. Tibial is a nerve for posterior compartment of leg, And that is why the tibial nerve is also known as posterior tibial nerve. Okay, tibial nerve for posterior, for the posterior compartment of leg. Then the common peroneal nerve, when it is running, it winds around the neck of fibula. This is a very, very important point. It divides into two branches, deep and the superficial. And now it is a deep peroneal nerve, which is a nerve for anterior compartment. And whatever is left, we give it to lateral. Lateral. Superficial peroneal nerve left, go to the lateral side, lateral compartment. So we basically remember for what? We basically remember for anterior compartment and posterior. And if you are able to memorize for anterior and the posterior, whatever is left, we give it to lateral side for the lateral compartment. So the anterior compartment nerve is deep peroneal, posterior compartment nerve is tibial. The third nerve which is left is superficial peroneal nerve, we give it to lateral side. This is what we have talked about the nerves for each compartment of leg, and it is accordingly supplying in the each compartment the muscles. Now when you say sensory supply, in the sensory supply, now first of all the deep peroneal, it supplies the skin of the first web space. So if you see this image, in the first web space, the deep peroneal, and you can see this pink dotted area over here. This is the majority of area supplied by superficial peroneal. So you can see the majority of area on the dorsum of foot, plus it is going to the leg area also. And in the leg area, it is going where? On the lateral aspect of leg. So whenever you are memorizing this, please memorize this image. If you memorize this image, you are able to answer the nerve injury questions. How? Because you will answer according to the sensory laws. If they mention any sensory laws, then according to the location of sensory laws, you can quickly tell that which nerve is injured. So first web space, deep peroneal, the majority of the area over here is superficial peroneal going on the lateral aspect of leg. And if you say, what is the portion left? You can see over here in this image, now this portion is left over here. So whatever portion is left in the leg area, medial side leg, along with this medial aspect or the medial border of the foot, it is actually supplied by some other nerve, which is saphenous nerve. So the main is deep peroneal, superficial peroneal. Then we also mentioned that the rest of the area, medial side area, is saphenous nerve. The saphenous nerve is a different nerve. It is actually a branch of femoral. It is actually the branch of the femoral nerve. So this is supplying the medial area. So main we say is deep peroneal and the superficial peroneal. Now you will say, ma'am, what about tibial? What is tibial doing? The tibial is supplying the whole skin of the sole of the foot. So towards the sole, you are having tibial. So if any sensory symptom, if any sensory loss is towards the sole, you say tibial. And if any sensory loss is towards the dorsum of foot, you say superficial peroneal. Or if they say sensory loss specifically in the first web space, it is deep peroneal. So if you memorize this page very well, you can answer all the questions related to nerve injuries and leg area. Now when you are saying anterior compartment, deep peroneal, posterior compartment, tibial nerve, so we accordingly mention the nerve supply also over here. Anterior compartment, you are having three muscles and you answer accordingly. If you see the name of the muscle, tibialis anterior. So we identify the muscle according to the name. When you see read the name, you can tell this is the anterior compartment muscle. Like tibialis anterior, the word is already anterior, and extensors. So these are all anterior side muscles. Extensors are on the anterior side. So that is why all are supplied by deep peroneal nerve. Opposite to this, tibialis posterior, flexors, popliteus in the popliteal fossa, calf muscles, soleus gastrocnemius, all where? All on the posterior side. So all are supplied by tibial nerve. All are supplied by tibial nerve. Now, for the image-based question, we say the image-based question, this image is more important. You should be able to identify this image. And now if I say any tendon, you can see this pink color tendon is going to the great toe, that is the extensor hallucis longus. If any tendon is going to the rest of the toes, that is the extensor digitorum longus. If any muscle is finishing early, it is finishing in the middle of the foot, tibialis anterior. So for the image-based question in the leg, this image is important for you. Fine. Now, when you're talking about the actions over here, we say anterior compartment. It is all the muscles, they are having a common action. Common action is dorsiflexion, and opposite of this, posterior compartment, all the muscles having the common action, which is plantar flexion. So now in the leg also you can see, we remember the nerve of each compartment. According to the nerve, we are able to answer the muscles of each compartment. And the action is also, again, we are memorizing common action. Anterior compartment, it is the anterior compartment, we mentioned that the action is dorsiflexion. Posterior compartment is plantar flexion. So it is dorsi and the plantar flexion, which is occurring at the level of foot, occurs at ankle joint. Which joint? Ankle joint. Only one movement occurs at ankle joint, dorsi and the plantar. Whenever you are seeing eversion and inversion, another movement, it is not at ankle, it is at foot. It is at the level of foot. So we say the joint which is responsible is either the subtalar joint or the talocalcaneonavicular joint. So this movement is at the level of foot. Eversion by both peroneus. Inversion by both tibialis. So eversion by both peroneus, inversion by both tibialis. And now you say, ma'am, peroneus. What is this peroneus? The peroneus, longus and brevis, these are the muscles of lateral compartment. And the action we just mentioned is eversion of the foot. The nerve we already mentioned was superficial peroneal nerve. So very important, eversion and inversion at subtalar or talocalcaneonavicular, dorsi and plantar flexion at ankle joint. And now we come to the clinical aspect over here. So one clinical aspect, mainly foot drop. And now you should be able to answer the foot drop. When the foot drop is there, first best answer is common peroneal nerve injury. Because it is related to the neck of fibula, so it is having more chances of injury. Common peroneal nerve injury. If it is not given, then you will go for deep peroneal. When the common peroneal nerve injury is there, a lot of symptoms are there: loss of dorsiflexion, loss of eversion, a lot of sensory loss. But when the deep peroneal nerve is gone, we say like mainly it is one symptom, which is loss of dorsiflexion. So over here for the foot drop, you should be knowing which is the first best answer, common peroneal. If it is not given, then you go for the second best answer, which is deep peroneal. So remember, common peroneal. Why? Related to neck of fibula. So more chances of injury. Now, as you talk about the arteries over here, in this arteries, when we are talking about the arteries, we very well know that femoral artery, it is a continuation of external iliac. Then femoral artery forms popliteal artery. And now, after this, because till now everybody knows, and after this is the main thing, popliteal artery divides into two tibial branches, anterior, posterior. And if you see in the leg area over here, this is the anterior tibial artery, this is the posterior tibial artery. The anterior tibial artery continues towards the dorsum of foot, and this is now dorsalis pedis artery. The posterior tibial artery, if you see, is going towards the sole of the foot, and it is forming what? Plantar artery. This image is important for you. You should be able to identify the arteries in this image. And specifically, we say the very important artery is posterior tibial artery. Posterior tibial artery, and why it is important? Pulsation point. Its pulsation is felt over here between medial malleolus and tendocalcaneus with the foot in inversion. This is a very highly repeated point over here, and they can give you the image in which they put the fingers over here. The image of the foot is there, and they will put the fingers over here, and you have to identify that which artery is being pulsated. So just behind the medial malleolus, the artery pulsated is posterior tibial artery. Okay, it is a posterior tibial artery. For the veins, we say a very, very important vein is the great saphenous vein and the small saphenous. Like the superficial veins are saphenous veins. And whenever we are talking about the blood flow over here, we say that superficial veins are there, deep veins are there, connected by perforators, and the direction of the blood flow is from superficial to the deep. Only one direction of the blood flow is there, superficial to deep. And a very, very important point over here is that great saphenous vein is related to a structure which is saphenous nerve. This is important for clinical aspect. If you are doing any surgical intervention on great saphenous nerve, very high chances that you can injure a nerve, saphenous nerve. So this can be asked as a clinical point. Then as you talk about the dermatomes of lower limb, over here we remember this point that anterior side we have lumbars, posterior side we have sacral, anterior side lumbar counting is going downwards, posterior side sacral the counting is going upwards. So it is like this. Lumbar counting is going downwards, sacral the counting is going upwards. And if you see this image, same thing is there, 1, 2, 3, L1, L2, L3. Only the difference is over here in L4. So we remember L4 separately, that L4 is supplying which aspect? It is supplying it is a dermatome where on the medial aspect of the leg. Okay, it is on the medial aspect of the leg. So on the other side, of course, it will be L5. And when you see the sacral, the counting is simply going up. So over here, we remember this point, and then we basically remember L4, which is slightly different on the medial aspect of leg. Now in this X-ray images, this is a very, very important image, which is a highly expected image. Very easy to identify the structures, the pubic symphysis, this is the obturator foramen. And apart from this, what we actually expect over here in this image, they can ask you greater and the lesser trochanter. So you should be able to answer greater and the lesser trochanter also. Another X-ray which is very important is the superior view of the foot. In the superior view of foot, you should be able to identify navicular, in front of navicular cuneiform, and we confirm how we say navicular is present on medial side of the foot. And on the lateral side, you have cuboid. So very, very important bones over here. You should be able to identify this superior view of the foot. Now the three clinical aspects which are very important for us, and what are these three clinical aspects over here? One, you can see it is written over here, housemaid's knee, prepatellar bursitis, clergyman knee, infrapatellar bursitis. So for example, if I am talking about prepatellar, like if I am saying there is a knee joint, femur is there, tibia is there. Of course, we say the patella is in front of it. Okay, the patella is slightly over here and we say it is in front of it. So patella almost over here. So if I am saying any bursa in front of the patella, that is prepatellar bursitis. If any bursa above this, suprapatellar. If any bursa below it, infrapatellar bursitis. So if the image is given, you should be able to tell that in front of the knee joint you have prepatellar bursa, above it suprapatellar bursa, below it infrapatellar bursa. And we are clinically more concerned about prepatellar and infrapatellar bursa. Then another aspect over here, tarsal tunnel syndrome. This is also important for clinical aspect. It is a compression of what? Tibial nerve. And if the tibial nerve compression is there, where will you see tingling and numbness? The tingling and numbness will be seen on the sole of the foot. In this, the tingling and numbness will be seen towards the sole of the foot. Okay, so let us start with the abdomen portion. Now, when you talk about the abdomen portion, you can see one of the point is written over here, expected. Why? Last year, subcostal plane was asked. This year, January, transtubercular. This year, in the July exam, the supracrustal plane was asked. So one plane they are asking one time, and now we are very highly expecting that they can ask you the transpyloric plane. So in fact, you should be knowing all the planes. When you see this image, above is subcostal at the level of L3. Below is transtubercular, which is L5. And we say for both of them, it is upper border. For both of them, it is upper border. So these are the two main planes over here. And now when you talk about the other planes, then you are having transpyloric at the level of L1. lower border. Supracrystal, it is at lower border of L4. This is what? This is actually the plane passing through highest point of iliac crest. These are the other two planes. So first of all, we talk about the subcoastal and transtubercular, which are the main planes for the quadrants, and then we talk about the two other planes, transpaloric and the supracrystal. Then after that, and as we are talking about the other components over here, very important point is inguinal ligament. It is formed by the thickening of which muscle? So we say the inguinal ligament is formed by the thickening of external oblique aponeurosis. So it is the external oblique aponeurosis which thickens to form this inguinal ligament. A very, very important aspect. Then another is inguinal region, which is like a very high yield topic. You should be knowing all the points in the inguinal region. In the inguinal region, superficial ring, in the outermost layer, external oblique aponeurosis, deep inguinal ring, in the deeper layer, fascia transversalis. So the superficial ring on the outermost side. So that is why you say external oblique aponeurosis. And when you say deep inguinal ring, we say in the deeper layer, fascia transversalis. If you remember, we memorize like this, that these four layers together, outermost, external oblique, superficial ring. Innermost, fascia transversalis, deep inguinal ring. And when we were talking about the inguinal canal boundaries, in that also we use this thing. We said outermost or anteriormost, external oblique, forming the anterior wall, posteriormost side, fascia transversalis forming the posterior wall. In between, whatever two structures are there, they are forming what? These two structures are forming the roof. And when you talk about the floor is formed by inguinal ligament and lacunar ligament. So you know that inguinal ligament is this yellow colored ligament over here below the inguinal canal. So that is why the inguinal ligament was forming the floor. So the same funda we utilize to memorize the boundaries of the inguinal canal. This is the boundaries of the inguinal canal. And now the question comes, what passes through it? So we very well know the spermatic cord or the spermatic cord in the males or the round ligament of uterus in females. But what is the main thing over here is that what is the other structure passing through it? What is the other structure passing through it? The other structure passing through it is a very small nerve, ilioinguinal nerve. So you should be knowing that the other structure is ilioinguinal nerve. Then Hasselbeck's triangle, what are the boundaries of Hasselbeck's triangle? Medial side, rectus abdominis, lateral side, inferior epigastric vessels, and inferior side, inguinal ligament. If they ask in detail, so we say which border of rectus abdominis? It is the lateral border of rectus abdominis. So Hasselbeck's triangle, medially rectus abdominis, laterally inferior epigastric vessels, inferiorly inguinal ligament. Inferiorly is always the inguinal ligament. So over here for the inguinal canal, if you remember, for the inguinal canal, this funda you should remember, four muscles, these four layers we have mentioned in the inguinal canal. And according to that, we memorize the location of the rings also, and we memorize the boundaries of the inguinal canal also. Now the next we talk about the clinical aspect over here, a difference between the femoral and the inguinal hernia. First thing we mention is its relation with the pubic tubercle. And we memorize for what? Yes, we memorize for the femoral hernia. If we memorize for the femoral hernia, just opposite is for inguinal hernia. So we memorize for femoral hernia only. Femoral hernia where it is in the lower limb. So according to that, we say femoral hernia is below and lateral. It is below and lateral to the pubic tubercle. So femoral hernia going to the femoral area in the lower limb. So therefore we say whatever swelling is there, it is below and lateral. Opposite of that, above and medial is inguinal. So we memorize this one only. And now we say it is passing through what structures? So femoral passes through all the femoral structures like femoral ring, femoral canal. And when you say inguinal hernia, in that specifically we mention the indirect. It is an indirect inguinal hernia which is actually passing through this whole canal type area. So first of all, it passes through deep inguinal ring, then inguinal canal, then superficial inguinal ring, and the indirect inguinal hernia can reach till scrotum. So if they ask you the question that which of the hernia, the intestinal loop reaches till the scrotum, then the answer is indirect inguinal hernia. It is an indirect inguinal hernia. So this is one of the clinical aspect which we have discussed over here. Okay, the clinical aspect which we have discussed over here. Now we talk about the abdominal aorta, branches, arteries. For the abdominal aorta, first thing, it finishes at what level? L4. It finishes at L4, divides, terminal branches are common iliac. The common iliac further divides into external and internal. Now, when we are talking about this, basically you should be able to memorize in the image. You should be able to identify the arteries in the image. If this is the aorta, terminates into common iliac, this one. It gives a branch on the outer side, which is external iliac. It gives a branch on the inner side, which is internal iliac. So whenever this image is given to you, you should be able to identify these arteries, iliac arteries. Okay, this is for the image. Now, when we are talking about the aorta, abdominal aorta, what are the main branches? The main branches we say are these three branches: celiac trunk, superior mesenteric, inferior mesenteric. These are the three main branches: celiac trunk, superior mesenteric, inferior mesenteric. Now, if you say terminal branches that we have already mentioned, it is a common iliac, the right and the left. Now, another artery which is also asked separately as a question is testicular artery. They say testicular artery arises from where? So, we say directly arises from abdominal aorta. So, these are the main arteries over here. So, we say terminal branches, we already know, common iliac. Then apart from that, celiac trunk, superior mesenteric, inferior mesenteric. And then we mentioned testicular artery, which is from aorta itself. Now, when we are talking about the other three branches, these three branches, to memorize it, we actually memorize by this easy fund. Like this funda we have mentioned over here, by this easy funda. If I'm saying the whole GI system is supplied by these three arteries, then the whole GI system we divide into three parts. First junction at second part of duodenum. Second, we have chosen the transverse colon. And if you divide the whole GIT into the three portions by this, then we say upper portion supplied by celiac trunk, middle portion by superior mesenteric, lower portion by inferior mesenteric. Now, this is a funda which we use to memorize the area for each of the arteries. So it becomes easier for us to memorize the arteries also. What are the branches about it? Now, first we talk about the celiac trunk. Now, when we are talking about celiac trunk, the first and the most important thing over here is what are the three branches of celiac trunk. So, for the celiac trunk, we say the first thing is three branches by this. What are the three branches? Left gastric, splenic, common hepatic. It is a left gastric, splenic, common hepatic. When you see in the image, when you see in this image, this is the location of celiac trunk. Any branch going to stomach is left gastric. Any branch going to spleen is splenic artery. Any branch going to the liver is common hepatic. Right. Now over here we say what are the other arteries which you should be able to tell. Whenever you are talking about the arteries, we say towards the lesser curvature of stomach, you have the gastric arteries, and towards the greater curvature of stomach, you have gastroepiploic artery. So now this gastroepiploic artery is very, very important to identify. So for the image-based question, you should be able to tell these important landmarks in this image. The gastroepiploic artery towards the greater curvature. The one which is coming from left side is left gastroepiploic, and the one coming from the right side is right gastroepiploic. Very important, the gastroepiploic artery is one of the expected question. The left gastroepiploic takes origin from where? Splenic. The right gastroepiploic, it arises from common hepatic. So common hepatic artery, it actually gives a branch gastroduodenal, and the gastroduodenal further gives right gastroepiploic. So gastroepiploic is very, very important over here. Now, when you say superior mesenteric artery, which is the main artery over here, the main artery over here is appendicular. The appendicular, which is taking origin from ileocolic artery. Very, very important. Appendicular from ileocolic. So for the celiac trunk, three main branches and another is gastroepiploic. Over here, superior mesenteric appendicular artery, which is coming from this ileocolic. And for inferior mesenteric, we say a very, very important artery is superior rectal artery. It is the main branch of inferior mesenteric. Okay, main branch of inferior mesenteric. So now this is for these arteries, and now we say one more artery is there, which is internal iliac. And for this, we remember a keyword is pelvis. For the internal iliac artery, what we say? Yes, it is supplying all the structures inside the pelvic cavity. So whatever structures are there inside the pelvic cavity, around the pelvis, the bony pelvis itself, all are supplied by internal iliac artery. And the most important arteries over here is what? Uterine artery and internal pudendal. These are the most important branches over here. Uterine and internal pudendal. Now, as we talk about the vein over here, for the vein we say you are having two main veins, portal vein, inferior vena cava. Now, for the portal vein formation at what level? L1. Inferior vena cava formation at what level? L5. For the portal vein formation by union of splenic vein and superior mesenteric. It is formed by the union of splenic vein and superior mesenteric. Okay, splenic vein and superior mesenteric over here. Then another point we mentioned for the portal vein is that inferior mesenteric vein. If you see, this is the inferior mesenteric vein, it drains into splenic. It drains into splenic. So total we say all these three veins are pouring their blood into portal vein. And specifically it is formed by the union of 2S, that is splenic and superior mesenteric. Now another aspect over here is that these two venous system, they are anastomosing, the branches are anastomosing and form the portocaval anastomosis. The portocaval anastomosis is between the branches or tributaries of portal vein and vena cava system. And there are three main locations for that: lower end of esophagus, umbilicus, and yes, lower part of rectum and anal canal. These are the three main locations for what? Portocaval anastomosis. And for this portocaval anastomosis, if like any clinical aspect is asked from you and they say that due to some obstruction, the portocaval anastomosis, they have become enlarged. So they present as a clinical situation. Over here, at the esophagus, they present as esophageal varices. At umbilicus, they present as caput medusae. Towards this portion, it represents as hemorrhoids. So this is the clinical aspect over here. Plus, you should be knowing the portocaval anastomosis. These are the three main locations. Okay, these are the three main locations for portocaval anastomosis. Now, as we talk about the stomach, a very important aspect, there is one structure attached to lesser curvature of stomach, another structure attached to the greater curvature. Lesser curvature, lesser omentum. It is a lesser omentum. Greater curvature, greater omentum. So lesser curvature, lesser omentum, which is actually from liver to the stomach. So from the liver to the lesser curvature of stomach, greater curvature, greater omentum. The greater omentum is also known as policeman of abdomen. Now, whenever we are talking about the stomach, you should be knowing lesser omentum, greater omentum. And now you know that which curvature, which omentum. Now, in the stomach, we say stomach bed. And in the stomach bed, very characteristically, we say what structure is not forming the stomach bed. The structure which is not forming the stomach bed is spleen. Spleen is not forming the stomach bed. So for the stomach bed, we say spleen is not forming the stomach bed. Now, when we talk about the spleen, in the spleen, if you say spleen, spleen is where? On the left side. It is on the left side. and it is related to various structures, like spleen over here is related to stomach, kidney on the left side, which is the left kidney, and now splenic flexure of colon, and very importantly we say pancreas. Which part of pancreas? Tail of pancreas. So when we are talking about this, we say if this is the spleen, it is related to the stomach over here. This is the stomach, shown as stomach. Splenic flexure of colon, left kidney shown in the yellow color, and in the blue color we have shown pancreas. It is the tail of pancreas reaching here. So these are the relations of the spleen we just mentioned. And in the pancreas we say which part? It is the tail of pancreas. Now when we are talking about the spleen, the most important point in the spleen is this point. What is this point? This is the splenorenal ligament or the lienorenal ligament from the spleen to the left kidney. What is the contents of this ligament? So when we say splenorenal or lienorenal ligament, what are the contents? Yes, splenic vessels, tail of pancreas. Splenic vessels, tail of pancreas. Very, very important. Very, 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 very important. What are the contents over here? Tail of pancreas, splenic vessels. Tail of pancreas, splenic vessels. They are where? Splenorenal ligament. Then as you are talking about the one-liners, like the one-liners, if they come, they can ask you about the red pulp, white pulp. They are present where? The red pulp, white pulp in the spleen. In the red pulp, you are having Billroth cords. In the white pulp, you are having pals. Pals is periarteriolar lymphatic sheath. So these are like one-liners which can be asked, but the most important, as I told you, is splenorenal ligament. Now another one-liners which can be asked is Brunner's gland, duodenum, Peyer's patch, ileum, space of Dissay, liver, Hesser's corpuscle, thymus. These are other one-liners. Then apart from this, we say the duodenum is having 4 parts, in which in the 4 parts we say longest is third part. And whenever you are seeing the duodenum, you should be able to identify the parts of the duodenum. You know that first horizontal part is first part, then as it goes vertically down is second, when it again runs horizontally it is a third, and the fourth part is the last portion which slightly ascends upwards. That is the last very small portion, fourth part. Now another point over here is Conrad's classification for the liver. In the Conrad's classification, we again divide the lobes into small segments. And now the point is how we divide. So according to the branching pattern of what? Portal vein. So according to the branching pattern of portal vein. Portal vein as well as we say hepatic vein. So the main is portal vein. Total 8 segments. First 4 segments in left lobe. The rest of the 4 segments in right lobe. And for the caudate lobe we say specifically first segment. But the very important point over here is that according to the branching pattern of what? Portal vein plus also hepatic vein. Now in the liver we also say one more aspect is very frequently asked, which is the Calot's triangle boundaries. For the Calot's triangle boundaries, mainly the confusion is this boundary. So now you know for the Calot's triangle, one is a common hepatic duct, then you have cystic duct, and the third boundary is formed by what? Calot's cystic artery. It is a cystic artery. So for the Calot's triangle, the third boundary which is there is cystic artery. Common hepatic duct, then cystic duct, third boundary is cystic artery. Now as we are talking about the opening of the common bile duct and main and this pancreatic duct, both of them, they are having a common opening where major duodenal papilla. In which part of duodenum? It is in the second part of the duodenum. It is in the second part of duodenum, major duodenal papilla. So both the ducts, they are having a same opening. Now as you are talking about the kidney over here, in the kidney, like mainly we say that over here again the name structures are there, like Malpighian corpuscle, and the ducta bellini, which are specifically in the kidney. And on the posterior side, it is related to three muscles, medial to lateral: psoas major, quadratus lumborum, transversus abdominis. And when you talk about this, you should be knowing in this image. First muscle, psoas major. This is a vertebral column. Adjacent to it, this muscle is psoas major. Lateral to it, quadratus lumborum. As you go more lateral, transversus abdominis. So just above it, the kidney is placed. So the kidney is related to the three muscles from medial to lateral side. And you should be knowing that this is the location of psoas major. Then as we are talking about the urethra, in the urethra we very importantly say bulbar urethral rupture. Very, very important and a frequently asked question for the bulbar urethral rupture. So we remember over here the bulbar is superficial. Bulbar we remember is superficial. So that is why everything superficial is related to bulbar urethra. So bulbar is superficial. Okay, what we remember is bulbar is superficial. So that is why the extravasation is also superficial over here, and it collects in which pouch? In the superficial perineal pouch. And all the urine collection is towards the outer side or towards the superficial side. The urine collection in the superficial perineal pouch, it can go to the scrotum, it can go to the penile region, or it can go further towards the anti-abdominal wall. So all the urine collection to the superficial side, and very, very important over here, which perineal pouch? Superficial. Or sometimes they say urine collection is occurring in the anti-abdominal wall. So which urethra is ruptured? Yes, bulbar urethra is ruptured. So everything superficial for bulbar, opposite of that, membranous urethra, everything in the deeper aspect. It goes towards the deep perineal pouch, it goes deeply towards and the urine collects around the prostate and around the urinary bladder. So when we say membranous urethral rupture, so when the rupture occurs, the urine is going like this in the deeper side, and the urine collects around the prostate and around the urinary bladder. And whenever we are talking about this collection, we say if this is peritoneum, so the collection is outside the peritoneal cavity, or you can say below this peritoneum. So whenever the collection is inside the peritoneal cavity, whatever this collection of the urine is occurring over here, it is always outside the peritoneum. So remember that this collection is occurring outside the peritoneum area. So over here we basically remember what? We mainly remember the bulbar urethra. Bulbar is superficial. And according to that we memorize this component. The deeper aspect we have the membranous. So we say everything membranous is associated with deeper aspect. Now, as we talk about the uterus, we say two angles are there: angle of anteflexion, angle of anteversion, due to which the normal position of the uterus is anteverted, anteflexed. Among the two angles, more is important is angle of anteflexion, 120 to 124 degree. Okay, this is more important, 120 to 124 degree. Now over here we say the main artery which is supplying the uterus is uterine artery, and sometimes they ask you this sequence, that what is the sequence of the branches over here. But mainly in the uterus they ask you the angles, this angles over here, angle of anteflexion, and another question is on supports of the uterus. The supports of uterus: muscle support, ligament support, angles. Muscles are perineum muscles, perineal body, levator ani. All these ligaments are supporting. And we say like one ligament is there which is not supporting the uterus. It is a broad ligament. So always remember that broad ligament does not provide support to the uterus. It is not providing support to the uterus because it is a false ligament. So we say all these structures they provide support to the uterus except broad ligament. When you say round ligament, the round ligament is actually attached over here to the lateral angle of uterus, and it pulls the uterus anteriorly. So it is going on the anterior side. So because it is pulling the uterus anteriorly, sometimes they ask you that which ligament helps to maintain the angles of the uterus. So we say it is a round ligament because it is pulling slightly on the anterior side. So we say it maintains the angles of the uterus. It helps to maintain the angles of the uterus. So this is the location of round ligament. So mainly the angles and supports. In the supports also we say broad ligament not providing support to the uterus. Then as we talk about this male reproductive structure over here, we should be knowing that when we are talking about the ductal system, this is the sequence of the ductal system. The seminiferous tubule further is continuing into straight tubule, further tetatestis, further efferent ductus, and further is the epididymis. This is a sequence. Sometimes they ask you the question on the sequence. So you should be aware of the sequence. And over here in the testis, mainly they focus on this clinical aspect. When we are talking about the descent of testis, we know that from the abdominal cavity, it reaches the deep ring, inguinal canal, superficial ring, and then to scrotum. If the descent is arrested in between, then it is given the term as undescended testis. In that case, either the testis is present at the superficial ring or inguinal canal or the deep ring. It will be located at any of the location. But if the testis is located at a totally different location, like in the lower limb, or you can say it is in the upper abdominal cavity, so it is a totally different location. We say totally abnormal location, which is not in the path of the descent. Now it is known as ectopic. So this clinical aspect should be clear to you. You should be able to differentiate which is undescended and which is the ectopic. Now, as you talk about the perineum, now in the perineum, we say that a main muscle is levator ani. Whatever muscle you see completely over here, this whole muscle is the levator ani muscle, which you can see over here. And the question is usually on like what are the main components of levator ani. So in the main components, we say these are the three main components in which we say ilio, pubo, pubo. Okay, it is ilio, pubo, pubo. And when you are saying ilio, pubo, pubo are the components of levator ani. So which is not a component? Ischiococcygis is not a component of levator ani. So that is why we remember ilio, pubo, pubo, not ischio. Okay, not ischio. So ilio, pubo, pubo. They are components of levator ani. And similarly, when you are talking about this perineal body, you can see this location of the perineal body whenever you see the image. In the center of the image, perineal body. So if this is the location of perineal body in the center, it is present just anterior to the anal opening. And for the perineal body also we say a lot of muscles are attached to it, but one muscle is there which is not attached to it, and that is what? Ischiocavernosus. It is the ischiocavernosus. So over here basically in the abdomen we have mentioned 4 knots. 4 knots are there. One knot you can see over here, perineal body. Which muscle is not attached? Ischiocavernosus. Second, levator ani, which is not a component. Ischiococcygis is not a component. Third, uterus. Which ligament is not providing support? Not providing support is broad ligament. Fourth, stomach bed. Which structure is not forming stomach bed? Spleen. So we have memorized 4 knots over here which will actually help us to answer the questions related to these 4 components. Now, yes, very, very important this transverse section. And whenever this transverse section is there, as you see vertebra, you quickly say this is the posterior side. Okay, this is the posterior side of abdomen, anterior and the posterior side. Then when you see a very bigger triangular section, that is liver, adjacent to it, stomach, and a very small triangle is spleen. Accordingly, you can say this is the right and the left side. So spleen is also always like a small triangle which is shifted to one side. So spleen is a very small triangle. Then as you see on the posterior side of image, on the posterior aspect, this is the vertebral column. On the either aspect of vertebral column, you are having kidney, the right and the left kidney. Now, when you see the vertebra, always we mention in front of the vertebra. What do you see? Over here also, this is a vertebra. In front of the vertebra, what do you see? This is the aorta. Which aorta? Descending. Always it is descending. So when we are talking about the vertebra, always in front of it is the descending aorta. Now over here, one more structure we are adding slightly on the right side. What you see, some venous structure which is inferior vena cava, and it is more towards the side of liver. So that is why slightly on the right side. So all these are the main structures. You should be able to identify the kidney, spleen, liver, stomach, and the aorta, descending aorta, and the inferior vena cava. What are the other structures you should be able to identify is this fold between the liver and the stomach. This fold is lesser omentum. And when you're talking about this lesser omentum, when you see the lesser omentum, this is the fold lesser omentum. Towards the side of stomach, some sections are shown. Towards the side of liver, some small sections are shown. Now, towards the side of stomach, it is a gastric vessels. Towards the side of liver are these three structures which we name as portal tract, which are together given the term as portal tract. So this is about the lesser omentum over here and the structures which are present over here. Now what is another thing? Yes, let us first of all see this image. This image is, okay, let us first of all, okay, you must have seen this image now. What we have shown is that these three structure together. Now ligament between the stomach and spleen is gastrosplenic ligament, and if we see any ligament between the spleen and kidney, it is what? Splenorenal ligament. So if you see the same thing in this image, and if I ask you the pink colored ligament, it is what? Then we say gastrosplenic ligament. And if I say what is this blue colored ligament, this is splenorenal ligament. So what we see over here is that we have mentioned these two ligaments over here, which are shown in blue and the pink color. This is the stomach, this is the stomach, this is the spleen, and this is the left kidney. And between these three between these three structures, the ligaments which are attached, we have understood gastrosplenic and splenorenal. So now this is the complete image over here. Okay, this is the complete image, this is the complete section. If same thing is asked in CT section, radiographic image, exactly the same structures you can visualize. Okay, now as we talk about the embryology portion. So for the embryology portion, okay, for the embryology portion, we say that three phases are there. In that, which is the most important phase? Most important phase is embryonic phase. Which week? 3rd to 8th week. Now, in the embryology portion, like most of the students, they ask me a question, ma'am, in general embryology, what should we study so that we do it quickly and we are able to solve a lot of questions? So, like in that, you can just follow this revision video whenever you are studying the embryology portion. So, in the embryology, general embryology, we say 3rd till 8th week embryonic phase. And why it is more important? Because the congenital defects are usually seen in this phase. Then as you're talking about the spermatogenesis, you should be knowing these basic points, that formation in the seminiferous tubule, stored and motility is gained in the epididymis. The duration of the process is 74 days. Whenever you are talking about the steps over here, a very important step is which one? Is this step. When the primary is getting converted to secondary. Why? Because the chromosome number is reduced to half. That is why very important. The primary is having 46 chromosome and the secondary is having 23 chromosome. So that is why we say secondary, and after that spermatid, also spermatozoa, all are having 23 chromosomes. So that is why this step is very, very important. Then after that we say in the spermatozoa, the two main points is in the head we are having the nucleus, and in the middle piece the structure present is mitochondria. Now when you talk about the oogenesis, again the same thing is there. In this step, primary getting converted to secondary is very important. Why? primary is having 46 chromosome and the secondary is having 23 chromosome. Again the same thing. And now over here, very important point is that in the oogenesis you have polar body formation. So polar body formation in the oogenesis only. Now when we are talking about the steps, over here very important point is two arrests are occurring and you should be knowing that when is the arrest released. So the primary oocytes all are formed before birth, then they are arrested. First arrest released when? First arrest is released at puberty, just before ovulation, 24 to 36 hours before ovulation. So this is a very important point, that at puberty the arrest is released, then another second arrest is there, and the second arrest is released at what time? The second arrest is released at fertilization. So over here, very important for you is when is the arrest released? First arrest released just before ovulation at the puberty, and the second arrest is released at fertilization. Very important point. Now apart from this image based question is important for this image. In this image you should be able to identify the structures. When you are saying primary oocyte, it is having 4 follicles. First is primordial follicle. In the primordial follicle, like primary oocyte in the center, surrounded by one layer of cells. This is a primordial. Then when this oocyte, primary oocyte, is surrounded by multiple layer of cells, this is a primary follicle. Now in the same, when some cavity or antrum starts developing, that is the secondary follicle. And when the antrum, it grows, properly develops, this is the Graafian follicle. So you should be able to identify the 4 follicles in the image. Now after that, when the ovulation occurs, whatever structure is left behind, that is a corpus luteum. And then after that, it degenerates to form a very small fibrous like tissue, which is corpus albicans. So in this image, you should be able to identify these structures in this image. Now, whenever you are talking about the ovulation, the structure which is formed as secondary oocyte, and very important in the secondary oocyte is 2 outer layers. This layer is zona pellucida, and outer to it a cellular layer is corona radiata, the corona radiata. And whenever the fertilization has to occur, we say that the sperm has to pass through all these layers. So for the fertilization, what are the most important point is, first we say where does the fertilization occurs? So we say it occurs in the ampulla of fallopian tube. The most important step, ampulla of the fallopian tube. Another very important step is, what is the step which prevents polyspermy? So the step which prevents polyspermy is a third step, zona reaction, in which the zona pellucida becomes impermeable to the other sperms. That is the one which prevents polyspermy. So these 2 points are very important. Then apart from this, we say capacitation, which is required so that the cells, so that the sperm can pass through corona radiata. So capacitation process, it occurs in the fallopian tube of female genital tract, takes 7 hours so that the sperms can pass through corona radiata. But the 2 main things which are over here is fertilization in the ampulla, and very important thing, which step prevents polyspermy? That is the zona reaction. What happens in that? The zona pellucida becomes impermeable. It becomes impermeable. Now further, when we are talking about the developmental weeks, we say the first week is the most important, and in that also the point is, morula is a 16 cell stage formed on the 3rd day. It enters the uterine cavity on the 4th day. Blastocyst, it undergoes implantation on the 6th day. And in the blastocyst, the inner cell mass is the one which is embryoblast, and it forms the future embryo. These are the points which are very important in the first week. And these are the ones which are more frequently asked in the first week. Basically in the in all these weeks of development, these are the ones which are more commonly asked. Then another point which is more asked is when you come to the 3rd week. So in the 3rd week, we say gastrulation occurs, which is the 3 germ layer formation, and we memorize by 3 by 3. So 3 germ layers, they are formed in the 3rd week of intrauterine life. So we remember by this 3 4 3. 3 germ layers in 3rd week. And which is the first layer formed? It is the endoderm. So this is a very important point in the third week. Gastrulation, third, 3 for 3. Endoderm form first. And when we are talking about one more event which is occurring in the third week is a notochord. And what is important for that is, we say a very important point about this is, what is the adult remnant of notochord? The adult remnant of the notochord is nucleus pulposus of intervertebral disc. It is a nucleus pulposus of intervertebral disc. Now after that, you should be very well knowing that what are the two components which are forming the placenta. And you should be knowing the complete names. Decidua what? Decidua basalis. Plus chorion what? Chorion frondosum. So you should be knowing complete names, because whenever they are writing this combination, like in other options, they can give you some different combination. So Decidua basalis, which is a maternal component, plus chorion what? Yes. Yeah, chorion frondosum. It is a chorion frondosum, which is a fetal part. So these two names you should be memorizing very well. And when you are talking about the chorion part, the chorion we say are finger-like projection, primary, secondary, tertiary. And in this, what is there? Primary, we remember ST plus CT. ST is syncytotrophoblast, CT is cytotrophoblast. And now one component is added into it and it becomes different. So primary is ST plus CT. When EEM is added, EEM is extraembryonic mesoderm. When it is added, it becomes secondary. When one more component is added, fetal blood vessels, then it becomes tertiary. So this is an easier way to memorize the villi over here. And now when we are talking about these villi, so we say that these three structure, they are also contributing into placental barrier. The placental barrier means what? Placental barrier means it is a layers between the maternal and the fetal blood. So whatever are the layers in between, they are acting as barriers. So we say placental barrier. So again we mentioned the three layers: ST, CT, EEM. Syncytotrophoblast, cytotrophoblast, extraembryonic mesoderm. Plus one more, endothelium of blood vessels, fetal vessels. Endothelium of fetal vessels. So there are four structures which are forming the placental barrier. And one more thing we mentioned, that at 20 weeks, the layers are reduced. And they usually ask you that among these three layers, which layer is actually persisting, and we say that layer which persists is syncytotrophoblast. So among the three layers, this layer remains back. So this is for the placental barrier. Then the umbilical cord. In the umbilical cord, mainly they ask you how many umbilical artery, how many umbilical vein. So two umbilical artery, one umbilical vein. And when you say umbilical vein, which umbilical vein? It is a left umbilical vein. Okay, it is a which one? Left umbilical vein. And then they ask you very basic thing. Umbilical artery carries what? Deoxygenated blood. From where to where? From fetus to placenta. Umbilical vein carries what? Yes, oxygenated blood from where? Placenta to the fetus. A very basic thing. This you already know. Two arteries, one vein which is left umbilical vein. When you cut the umbilical cord, now they will degenerate and the remnants will be there. Umbilical vein forms ligamentum teres hepatis. Umbilical artery, proximal part forms superior vesical artery. It persists as superior vesical artery. Distal part forms medial umbilical ligament. And this is like very easy to remember: venosus, venosum, arteriosus, arteriosum. And among this also, we say the most important is umbilical vein, which is forming ligamentum teres hepatis. This is the one which is more important. Ligamentum teres hepatis. Okay, now as we talk about the systemic embryology, please remember over here, whenever you are doing the systemic embryology, please ensure that you have seen all the congenital defects, anomalies. Images you should be able to identify, and in one line you should be able to tell that what is the problem, what is the defect. Then another is pharyngeal apparatus. In the pharyngeal apparatus, the pharyngeal arches, pouches, these all structures. So in the systemic embryology, these are the two main points, main like topics. So whenever you are doing this, ensure that you have done this portion. Now, for the CNS development, we say a very important aspect is the congenital defects. What? Anencephaly. This is anencephaly. It comes under neural tube defects. And another is, this is spina bifida. The anencephaly is due to what? Defect in the closure of what? Yes, cranial neuropore or anterior neuropore. Both the names you should be knowing, cranial and anterior neuropore. And opposite of that, caudal or the posterior neuropore, the defect in the closure leads to spina bifida. So for example, if they have given you this image, you should be able to tell in one line, it is a defect in the cranial or the anterior neuropore. And you should be able to identify the image. Now over here, one more image is there, which is cranioachysis, which is the most severe form. It is most severe form of the neural tube defect, in which it is from head to the tail. And in this, we say the complete neural tube fusion is defective. So that is why it is the most severe form, and you should be able to identify that this is what? Cranioachysis, another neural tube defect. Now, apart from this, when we are talking about the structures over here, we say mainly we remember pons and cerebellum. They are developed from rhombencephalon. The pons and cerebellum from where? Rhombencephalon. Pons and cerebellum, rhombencephalon. Now, when we are talking about the GIT portion, in the GIT portion, we mainly memorize this schematic image. The whole gut tube divided into three parts: foregut, midgut, hindgut. What junction? Same junction. Second part of duodenum, transverse colon. For the second part of duodenum, specifically at the major duodenal papilla. And for the transverse colon, where? Yeah, yes, junction of right 2/3 and left 1/3. So now accordingly, you can tell what can be the derivatives of foregut, midgut and hindgut. Now apart from this, we say the depressions from outer side towards the cranial side, we have a depression stomodium, which forms the oral cavity. And towards the tail side, we have a depression from outside, which is proctodeum or anal pit. It is giving rise to lower part of anal canal. So if we know this schematic image, we can tell all the derivatives of GI portion, that they are derived from what? So this is the image which is very, very important for us. Then the artery for foregut is celiac trunk, midgut is superior mesenteric, hindgut is inferior mesenteric. Now, when we are talking about these gut portions, again the congenital anomaly is very, very important. One is this tracheoesophageal fistula. And whenever I am saying that there is a communication between this trachea and the esophagus, so we say there is defective formation of tracheoesophageal septum. The tracheoesophageal septum, it separates the trachea from esophagus. It completely develops. If it is not properly developed, then we say it leads to tracheoesophageal fistula. Then apart from that, in the foregut, we can tell the derivatives according to the schematic image. Apart from that, we say foregut is also forming other structures like trachea, lung, liver, gallbladder, and the pancreas. And in that, we already mentioned this congenital defect, tracheoesophageal fistula. Now, when you are talking about pancreas, in this we remember ventral bud. There are two buds, ventral and dorsal. Ventral is forming lower part of head and uncinate process. So we remember this one, and the rest of the pancreas by dorsal. So basically we remember this image. If you remember this image, so you know that ventral is where? On the lower side. So lower part of head and uncinate process. And when we are so this is about, when we are talking about the pancreas, we say both the buds, they fuse to form the pancreas. Both the buds, they fuse to form the pancreas. If the buds, they don't fuse, then it leads to the most common congenital anomaly, which is known as pancreas divisum. It is a non-fusion of the buds, pancreas divisum. Another congenital anomaly is the annular pancreas. In the annular pancreas, what is there? This is the annular pancreas. What you see, the pancreatic tissue, it actually surrounds the duodenum like a ring. And it therefore creates the symptoms of duodenal obstruction also. So this is the image of annular pancreas. Okay, this is the image of annular pancreas. Now the next we talk about the midgut. Over here we say the main is this one. The vitreointestinal duct is, if you see this image, it is a duct or a communication between the midgut and umbilicus. So you can see this ductal combination. This is a ductal duct which is present between the midgut and umbilicus. And what happens? It usually degenerates. It will degenerate. But if it remains patent, what will happen? It will lead to a fistula known as wetline fistula, also the fecal fistula. And what will happen through this fistula? Whatever is present in the midgut, it will start coming out. And that you know what is present? Fecal material or the meconium. It starts coming out at the level of what? At the level of umbilicus. So very typical symptom is there that fecal material or the meconium comes out from the umbilicus. And when this typical symptom is there, you quickly say it is vitreointestinal duct which is completely patent. So this is a very important anomaly over here. If I say that only some part is patent, only the proximal part is patent, then it leads to Meckel's diverticulum. But the main is this one above, which we have discussed, this one, Wittline fistula. Now, apart from this, in the midgut, we also mentioned one more specific thing, that the physiological hernia occurs 6th week, then it returns back, reduction of the physiological hernia 10th week, rotation of the midgut, how much? 270-degree, direction anti-clockwise. Direction anti-clockwise. Axis of rotation, superior mesentery. Now over here also one congenital defect occurs is this one. And you can say that this can come as a new question, because this has not been asked till now. And if this condition is given to you, this is the exomphalos, also known as omphalocele. What is the basic defect? The basic defect is non-return of midgut. Okay, you can see non-return, or the word can be used over here, non-reduction. That is the same thing. The non-return or the non-reduction of the midgut loop. And whenever there is there, this condition is there, what you will see, the intestinal loop are present outside at the level of umbilicus, and they're covered by a membrane. That membrane is the amniotic membrane. So this is the omphalocele. And you should be able to compare it by the gastroschisis, in which the intestinal loops are just present outside, but no amniotic membrane is covering it. That is gastroschisis. It is actually a different defect. It is defect in the formation of anti-abdominal wall. And the main over here we say is omphalocele. Very, very important. Omphalocele, non-return, non-reduction of midgut. And you will see this image, intestinal loops at the level of umbilicus outside, covered by amniotic membrane. This is the omphalocele. Then as we talk about the hindgut, we say a main structure over here is, it is also forming one structure, urinary bladder. How? Cloaca, it forms urogenital sinus, which forms bladder. And a very important aspect over here is this clinical aspect. When we are talking about this clinical aspect, we say allantois is between urinary bladder and the umbilicus. Again, a duct over here between the bladder and the umbilicus. Actually, it closes. If it remains patent, then again it leads to fistula. And now the symptom is different. Now the urine or the fluid is coming at the level of umbilicus. And now when such symptom is there, when such symptom is there, when the urine or we say fluid is coming at the level of umbilicus, now you should think of what? Allantois. Allantois or allantoic duct. It is the same thing. So when you say fecal material from the umbilicus, vitreointestinal duct. When you say urine from the umbilicus, allantois. So these congenital anomalies is very important. And now the other points over here, when you memorize the mesentery, over here we memorize the dorsal mesentery. The dorsal mesentery forms greater omentum, very important, greater omentum. The spleen is formed over here, and as the spleen is formed over here, the ligaments of spleen are also formed by this. So dorsal mesentery forms greater omentum, spleen, and the ligaments of spleen. Then as you talk about the genitourinary system, over here we memorize mesonephric. We memorize the mesonephric and whatever, like by exclusion you can answer the paramesonephric. So what is mesonephric? We say M for mesonephric, M for males. It is forming the reproductive structures in the males. Okay, and over here we say the mesonephric duct is the main. Okay, M for mesonephric, M for males, and we say it is main. So whatever important structures are there, we give it to mesonephric. And in the mesonephric, mainly they ask about, for example, this structure. They say in both male and female, it is forming what? It is forming trigone of the bladder or ureter. So the mesonephric forms in both males and females urinary component, trigone of the bladder and ureter. Then you can see it is forming all the male reproductive structures. And now another question they usually ask about adult remnant in the female. Adult remnant is epiphoron, paraphoron, Gartner's duct. So like whatever names you see now, like they are very different or they look like very important. Everything you put it to mesonephric. Or by default, you can see like for any of these questions, they usually ask the question on the mesonephric. So everything is associated with mesonephric. All the main structures over here to mesonephric. Epiphoron, paraphoron, Gartner's duct, trigone bladder, then we say ureter, everything by mesonephric. Then apart from this, the gonadal ridge, it is important. We say it is contributing in the formation of ovary in the females and testes in the males, and these two structures are given the term as homologous organs or homologous structure. This is the gonadal ridge or the genital ridge. Now, when you are talking about the urinary system, in the urinary system, we mainly say that a clinical aspect over here, horseshoe kidney. For the horseshoe kidney, we very well see this image that lower poles are fused, the lower parts of the kidney are fused, and the ascent, when the kidney is trying to ascend upward, it is arrested. So the question is, the ascent is arrested by what? It is arrested by inferior mesenteric artery, and due to that, this fused portion is lying at L4 level. So this is the clinical aspect over here. Horseshoe kidney, arrest of ascent by inferior mesenteric artery, which level? L4 level. Now for the diaphragm, we say that mainly this image you should be knowing well. And when you see this image, so we basically remember that these are the two main components. What are the two main components? Septum transversum, PPM. Okay, two main components, and we remember like this: ST, PPM. So in the diaphragm, ST, PPM. And when you see the image, you say PPM. Two times P is there, so we say PPM is on the posterior side. So whenever you are identifying in the image, on the posterior side, PPM, orange colored area, and therefore the anterior side is ST. So two main structures over here: septum transversum, pleuroperitoneal membrane, and PPM, pleuroperitoneal membrane on the posterior side. Anterior side you have septum transversum. These are the two main structures which you should be able to identify in the image. Apart from this, if any other component is mentioned, if you see any contribution from lateral side, so it will be having a component named as lateral. The word we will be used is lateral, a contribution from lateral side. And if you have a projection from the posterior side, you can see this small projection is coming from the posterior side. This is a component 4, which is from posterior side. So we are having the word dorsal. So mainly what you will remember, these first two. And you should be able to identify in the image. If by chance they give in detail, then on the lateral side you have lateral component, and on the projection on the posterior side is dorsal mesentery of esophagus. So this is for the diaphragm. Now when you are talking about the pharyngeal apparatus, as I told you, this is a very, very important topic. In this we say, first of all, you should be able to identify the structures in this image. The arches are dark brown colored area, 1, 2, 3, 4, 6. These are the arches, which is a mesoderm. On the outer side, it is covered by ectoderm, and now you are having the depressions, the ectodermal clefts, 1, 2, 3, 4. What are these? These are clefts. These are the pharyngeal clefts. So in the center, mesoderm is there. Outside it is covered by ectoderm. Inside it is covered by endoderm. So the dark brown area is mesoderm, which is termed as arches. Outer side, it is covered by ectoderm. So depressions are there which are given the term as clefts. Inner side pink colored layer is endoderm, which is again covering it, and again the depressions are there which are given the term as pouches. And again you say this is the first pouch, second, third, and this is the fourth. These are the 4 pouches. So this image is important for image based question. So that is why I have discussed this image for image based question. And whenever you are memorizing the derivatives over here, we actually remember for what? We remember for the first arch. Very, very important. First arch. For the first arch, we have memorized by this mnemonic Masti, and we say the predominant alphabet is M. So whatever is derived from M, then A for anterior, S for sphenoid, T for tensor, I for incus. So these are the structures in this. We say mainly, which components already highlighted over here. Mainly we say mandible, muscles of mastication, nerve of this arch, mandibular nerve, artery of this arch, maxillary artery. All are M. You can see all are M. So like must for memorizing the first arch, very easy to remember. All the structures derived from M. And then we say one more structure is there, sphenomandibular ligament, which is I am writing as one of the new question which can come, one of the expected question over here, sphenomandibular ligament. So these are the main structures from the first arch. Now, if you remember from the first arch, you can by exclusion answer for second. And in the second arch, we mainly say is what? Stapes, styloid process, stapedial artery, facial nerve. These are the main. So you're having stapes over here. Malleus incus for the first arch, stapes for the second. So second arch stapes, stapedial artery also over here. Then we have styloid process also and the facial nerve. The stapedial artery, artery of second arch, facial nerve, nerve for second arch. So in the second arch, these are the 4 main structures. Now, when you're talking about the other arches, for the other arches, we like at present, mainly they are focusing on arteries. The third arch gives rise to carotid arteries, all carotid. Fourth arch on the left side forms arch of aorta. Sixth arch on the left side forms ductus arteriosus. Again, this is very, very important. One of the like new question which can come. Ductus arteriosus, left side, sixth arch. So the sixth arch artery on the left side, it forms ductus arteriosus. Now this is about the arches over here. Mainly we remember for the first arch. Then when we are talking about the pouches, in the pouches we mainly memorize third pouch. Okay, we mainly memorize third pouch, and we are having a very easy mnemonic for that. We say third for third. When you say third for third, TH is thymus, I is inferior parathyroid. So third for third, very easy to remember. Third pouch, third, mnemonic is third. TH thymus, I is inferior parathyroid. This is the most important third pouch. Apart from that, the second pouch is forming the palatine tonsil. Then as you talk about the cleft, you should be mainly knowing that cleft are responsible for the congenital defect, bronchial cyst or bronchial fistula, and both the cases it is the second ectodermal cleft which is responsible. So for the cleft we talk about the congenital defect, bronchial cyst or fistula, second cleft. Now apart from that we come to the cleft lip, and we say a very, very important aspect. Cleft lip you should be able to identify, and this is a non-fusion of what? It is a non-fusion of medial nasal process and maxillary process. So we say it is a non-fusion of medial nasal and the maxillary process, a very frequently asked clinical congenital defect. So cleft lip is due to non-fusion of medial nasal process and maxillary process. Now apart from this, you should be able to answer these other points also. The tympanic membrane is formed by all the 3 germ layers. Thyroid gland, thyroglossal duct, formed by this. Pituitary gland formed by Rathke's pouch. Fossa ovalis, I earlier also said fossa ovalis. Now what is important over here, that fossa ovalis is a remnant of what? So the first best answer is foramen ovale. If it is not given, then you go for septum primum. So basically there are 2 answers, foramen ovale If it is not given, then you go for septum primer. So over here, all the congenital anomaly is very, very important, and plus, as I said, pharyngeal apparatus. Now, lastly, when we talk about this histology portion, in this, mainly you should be able to tell the locations of the epithelium. Like for example, for the simple squamous, the most important location which is asked is alveoli of lung. Very, very important, alveoli of lung. They usually ask this example. Simple cuboidal, they ask thyroid follicle. This is the most important example, the thyroid gland, which they actually ask. Apart from that, germinal epithelium of ovary. It is the germinal epithelium of ovary. Now, for the simple columnar epithelium, it is present where in the stomach and the large intestine. If this same epithelium is having cilia, if the same epithelium is having the cilia, it is present where in the uterus and the fallopian tube. Now, if the same epithelium is having microvilli, gallbladder, small intestine. In the gallbladder, we basically say it is a brush border appearance. Now, this is a simple epithelium. When you say stratified, in the stratified, we say keratin. Keratin is skin, only on the skin. Keratinized stratified squamous only in the skin. Non-keratinized in the towards this tongue area, tonsil, esophagus, cornea, vagina. These are the specific locations, and whenever the keratinized epithelium is there, towards the upper side you are having a specific extra layer is present, which is keratin. In the non-keratinized, no keratin layer, but in the keratinized you are having the keratin layer. Then the pseudo-stratified ciliated columnar, specifically present in trachea, very, very important. Trachea epithelium is very, very important. Then the transitional epithelium, it is present in the ureter and the urinary bladder. And whenever you are talking about these epitheliums, you should be able to identify this in the image. So whenever you are seeing the image, you should be able to differentiate the H&E image of non-keratinized stratified squamous with keratinized stratified squamous. And as well as you should be able to identify transitional. This is a specific appearance of transitional with the pseudo-stratified columnar epithelium. This is a specific appearance of the pseudo-stratified. And lastly, we talk about the cartilages. Now, as we talk about the cartilages, we are having three types of cartilage: hyaline, elastic, fibro. And now we say what are the main examples of this. Hyaline cartilage, trachea; elastic cartilage, epiglottis; and fibrocartilage, intervertebral disc. Very, very important examples for each of the cartilage. And among the three cartilages, if I say which cartilage is not covered by perichondrium, that is fibrocartilage. And which cartilage can ossify with age? This is very important. Which cartilage can ossify with age? That is hyaline cartilage. This is the hyaline cartilage. So by this we end up the revision over here, and best of luck to all the students. Best of luck to all the students. Best wishes from my side. Do well in your exams, do well in your test, and the revision videos, they are very, very helpful. So whenever you are studying, always try to study from revision video. That will give you a motivation also, and that will increase your speed of revision also. Because when you are revising yourself, you may revise it very slowly, but if you have revision video in front of you, it may increase your speed. So best wishes to all of you. You all will do really well. And in the subject wise test also, which is upcoming, and other tests also which are upcoming, so whatever is given, all the questions are from the workbook only. No question is from outside. All the questions are from workbook. And just see, like while you are attempting the question, there may be some small twist which will help you to understand that if such kind of question comes in the exam, how you have to answer it. And whenever you're giving any test over here, like subject wise test or the mock test, whenever you are giving, your main focus should be that you have to learn from it. You have to learn from your mistakes. Don't assess yourself. ठीक है, assess मत करो कि हाई मेरे मार्क्स कम आए हैं तो इसका मतलब मैं अच्छा नहीं पढ़ रहा हूँ. नहीं 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 नहीं. Don't do this kind of judgment about yourself. No negative judgment about yourself. If the marks are less, you start saying, oh ma'am, I'm not studying well. No judgments for yourself. These tests, these questions, whatever you're getting, only for less, you marks कम आए हैं तो इसका मतलब मैं अच्छा नहीं पढ़ रहा हूँ. नहीं. To learn from it. You have to learn from your mistakes. Don't assess yourself. ठीक है, assess मत करो कि हाई मेरे marks कम आए हैं तो इसका मतलब मैं अच्छा नहीं पढ़ रहा हूँ. नहीं. Don't do this kind of judgment about yourself. No negative judgment about yourself. If the marks are less, you start saying, oh ma'am, I'm not studying well. No judgments for yourself. These tests, these questions, whatever you're getting, only for learning from it. If you do any mistake, learn from that mistake. तो सिर्फ समझने के लिए, सिर्फ आपकी गलतियों को सुधारने के लिए, एक आपको वो लेवल देने के लिए कि जब आपका एग्जाम आएगा तो इस तरह के क्वेश्चंस आएंगे तो कैसे आपको सोचना है. आज गलती हो सकती है बट उस दिन गलती नहीं होनी चाहिए. That is the thing which you have to clear up. Okay, so best wishes to all of you. Best wishes always from my side, and do well. So bye to all of you.